of time. From this survey, we can see the health workers were spending almost half the time or 3/4 of their time on outreaches, actually just doing ART refills. And if anybody's done an ART refill, all this means is giving patients a bottle of medicine and writing in a register. It doesn't need a highly trained nurse or doctor or even village health team member to do that. There are better things that they could be doing with their time. For example, antenatal testing, childhood immunizations, HIV testing and counseling, viral load screening. And so the idea about the Medical Drones Project from this baseline assessment is if we can take away the ART refills and all of that time that our healthcare workers are spending on this very simple activity, it means that they can spend more time on the more technical areas. And, you know, when you think about your innovations as you know, young innovators, you need to think about the pain that this will reduce for the healthcare workers, but not replacing our very, very valuable healthcare worker teams. So in Kallangala, Joanne has gone through this, but we have managed to deliver ART to 99 people living with HIV, and 63 of these have now had a year's worth of ART delivered through the drones. We've been asked to do top-ups by the health facility. So this is the health facility starting to use us as an additional resource for people who've, you know, dropped their drugs in the lake or had their medication stolen or left it on another island. We've done 184 flights total in Kallangala. The average flying time of these is about 9 minutes, but the boat time that would be taken is about 35, and our average flying distance is 6.6. For those of you who don't know Lake Victoria so well, it's actually a very shallow lake that is quite dangerous because it is so shallow. And even though we are a landlocked country, we're in the top 10 rates of drowning in the world. This lake is really dangerous. People die on the lake. The last time we were there, you know, her fisherman unfortunately was being brought in, having drowned the night before. So we don't want to risk the lives of our healthcare workers on the boats if we possibly can, as well as it being very, very costly and time consuming. So we've done a couple of sub-studies. So whilst people have evaluated if it's safe to and take hematology and biochemistry tests in the drone, nobody so far had looked at whether microbiology samples could be carried in the drone. So this was a study looking at gonorrhea samples, and we flew some in the boat, some in the drone, and some were taken just by boat. And then we evaluated them to see both whether you could see the bug under the microscope, but also whether you could grow the gonorrhea afterwards. So that the reason this is important is to test for antimicrobial resistance. It's useful to be able to grow the bugs in the laboratory that you've isolated. And what we found is there was no difference between the drone and the boat samples. In West Nile, we managed to deliver nearly 700 COVID samples during the large second wave of COVID earlier on this year. This was 83 flights with a mean flying time of 20 minutes and a distance of 14 kilometers. But really, most of these were flown across the 32 kilometers between Moyo and Adjumani, with about 500 grams of weight for each transport. We mainly did COVID samples, but we also tried taking some other, other things as well, such as blood samples and commodities. We also repeated the same type of testing with COVID samples, checking whether the COVID sample results were the same, whether we had taken them by drone and by boat. And what we found is actually the results were better from the drone samples. And this is likely because the boat samples took so long to get there. The tests didn't work so well on the samples that had gone on the boat. And what we found when we looked at turnaround time, and this is samples leaving the one laboratory to the results returned to the healthcare workers at the end of testing, the ground transport was taking about 20 hours to return the results, and the drone, we were getting this down to about 5 hours. When you look at the main reason for that difference, it's all to do with the time the samples were leaving and the time the samples were arriving. So the difference we made was in the transport time between the two centers. We've also started to look at a cost analysis. And this is in work in progress at the moment, but the sorts of things, you can't see it very well, I'm afraid, sorry. But the sorts of things we're looking at is the cost of recharging the batteries on the drone versus the cost of the fuel, the cost of the hardware, the cost of the staff to run the operations. So this session was meant to be about lessons learned, so I'll just finish in the last 3 slides. So Patrick and Joanne have kind of mentioned this already. This technology is rapidly evolving. You cannot at the moment go to a drone website and buy a drone and just start drone operations in a country. The technology needs to be tailored to your use case, and it needs off-the-shelf modifications. So our cargo box, which carries 7 bottles of antiretrovirals, is actually a 3D printed cargo box that's specifically designed for that purpose. We probably need, or we definitely need, different aircraft for different use cases. Even we were using 2 different aircraft between Kalangala and West Nile. And, you know, this over time, with more aircraft becoming available, this is going to be even more refined. Beyond visual line of sight flying is very challenging. What we're asking to do is to fly drones where you can't see them, and remotely controlling them. It's challenging for a number of reasons, and should not be undertaken lightly. But we're very lucky to have built, you know, this capacity in country. And, you know, this project wouldn't happen without the support of many people. There are, you know, the senior stakeholder steering committee is absolutely vital to this. But, you know, whenever we do operations, we let a lot of people know what's going on. We keep people involved. We keep people engaged all of the time. So our next steps in Kalangala are to expand the operations beyond the 17 peer support groups to all of the peer support groups on the landing sites that we're on. The drone that we have at the moment is kind of reaching its maximum capacity for the distances we're doing. So to expand to the rest of the district, we're going to have to evaluate some new drones that we will be doing over the next 6 months. And, you know, everybody keeps asking us, how much does it cost? So the piece of work that we're doing is going to be a policy brief around the costs of running different scenarios. We also have trained our peer support workers, but we want to do some formal curriculum development, so that there's actually a structured curriculum for the peer support workers who are approaching the drone, emptying the drone, which can then be used to train more peer support workers. In West Nile, we're undergoing a needs assessment. We're coming to the end of it for using drones in 10 facilities. So what different use cases can we use? What are the most important use cases for West Nile and for the facilities that we want to work in? We're undergoing the formal cost evaluation, you know, from the numbers that we showed, and we're looking to secure financing. So in the areas of ARTD and blood delivery vaccines, but also diagnostic tests. West Nile is a big region where there are lots and lots of outbreaks. We think that what might be very useful is to reduce the time that samples, especially for especially dangerous pathogens such as Ebola, Marburg, Zika, chikungunya fever, you know, any emerging infections can get to Entebbe Hospital to be evaluated quicker. If we can cut off some of that time, it means the outbreak response can be quicker. We would also hope that if we do identify an especially dangerous pathogen, we may be able to get vaccines to the outbreak site quickly, so that ring vaccination, for example, in Ebola, ring vaccination can happen around the contacts of those cases. So, like I said, this wouldn't be possible without the support of many, many, many people, including our UNCDF partners here today. And especially our peer support workers who've been so brilliant in, really engaging with the project and accepting to learn about the drones, make our landing sites safe, approach the drones, give out the drugs to their colleagues, and they've really helped us on all of these sites. Thank you so much.
Thank you so much.
So I think we have time. Could somebody give me a time check? Because we need to be finished by 1:30. Maybe we've got time for 1 or 2.
Yeah. We do 1 or 2 questions. So anyone has a question for the drones team? I don't know if it's going to fly in the room from one point to the other. That's my question. Everyone is saying yes, no. I'll leave that to Dr. Rose. But yeah, looks a very interesting. Yes. Another person?
Behind you.
Okay, we thought it would be 1 question. I'm coming. Okay.
Good morning. Thank you for the great presentation. My name is Livas Mook, representing ESF Innovation. My question goes to security. As you know, you'll be transporting some dangerous pathogens. So what is the plan if any case there's crash and you guys was transporting, let's say, Ebola samples? So what kind of protocol do you have? Thank you.
Thank you. That's a really good question. So we are not yet flying especially dangerous pathogens, but if we want to do that as the project, obviously there are safety things that we need to put in place. The group that we worked with at Johns Hopkins did quite a lot of testing of the cargo box, of stress testing. So dropping the cargo box, to see if blood sample bottles would leak or break. There are, ways that you can double bag and double pack to make sure that things do not leak. There are, and then there's the community side of things. So there's the community sensitization to explain to people what the drones are and to explain to people not to approach the drones. And a lot of that we've done on local radio and local radio announcements. But then there would also be messaging on the box, to say that this was dangerous, but probably to give some kind of, reward if you call us when you find the box and to tell you to not open the box. So it would have to be a multi-step approach. There would have to be multiple activities along those lines. The other thing is that, the drones would not be flying automated without somebody keeping an eye on them. So we would know where a drone went down. And obviously we would be able to deploy people quickly to that area. And normally, like with the landing map, we've got connections with the police and with the army in the areas that we would work. And it may be that we can get a security force to the site, quickly, or the local police, scramble the local police to the site, as what happened with our MAT. But with all these things, it's going to have to be multiple activities in order to make that safe. And before we start, we're going to have to get permissions. We're going to have to get ethical approvals and permissions to actually do it. We think it's a good use case, but of course, we're doctors, right? We do no harm first. So we have to make sure that we're doing it in a safe manner. But great question. Thanks.
Thank you. Good morning to you all. My question is, what is the capacity of the carrier, and are there plans of making it bigger to incorporate the delivery of other medical supplies?
Yeah, so great question. So the capacity of the drone is dependent on each use case. So this is what I was saying is you don't just kind of go and buy a drone and say, I want a drone that can carry 10 kilos. You design the drone or you pick the drone depending on what you want to use it for. And it's always a balance between how far you're flying and how much weight you can carry. So if you're flying long distances and you want to carry a large amount of weight, you need a very large drone to do that. So in Kalangala, our next step is to go for longer range drones that can perhaps carry a little bit more weight. But really, because the drone flights are so short and because they're just batteries, when you're doing the slightly longer flights, it's almost better to send the drone 2 or 3 times and get the distance because it doesn't really cost you very much to fly it. It just costs the price of recharging the batteries. So really weight is a consideration, but that also has to be in balance by how long the distance are. And the bigger the drone, the more expensive it is. So in order to make it sustainable, you know, it may be that it's a balance between having a medium-sized drone and doing 2 or 3 flights, you know, with just charging the drone in the meantime. So each different use case requires a balance of all of those different things to decide on which drone you use.
Thank you so much.
Thanks.
And just to lead on to that briefly, we have the Industrial Research Institute in the house. I'll just interrupt them a bit. Dr. Philippa is an industrial designer and her colleague. It will be interesting to know their perspective on how to build in-country support, to design some of these solutions, like, you know, the weight she's asking about and how the other people can be part of designing these systems in-country.
Yes, hello everyone. I used to work at the Uganda Industrial Research Institute, but I did a lot of work designing non-invasive medical devices locally. There's quite a lot of infrastructure at URI. There's a mechanical engineering department, so you can do quite a lot of design there. I was in the electronics department, so we have built that capacity. There's also 3D printing capacity, and there's an incubation program for startups and any innovator who's working on something technology related. So definitely my colleague here, Enid Kansime, please reach out to her. She can support you if you need any of those facilities.
Thank you so much. I think now we've got through our point, you know, proof of concept to say that we have the enabling infrastructure and environment for this in Uganda. Now, you know, hopefully our next steps are to continue to build the capacity, not just for the flying, but also for the drones themselves and the adaptation in country. So thank you so much. Thanks.
Thank you so much, the IDI team. I think the beauty of having such an organization do this fast is that now it's going to be easy for the rest of us to do. We don't have to go through all that they've gone through. We have the lessons and everything is now clear for us. Thank you so much. So I need to switch mics. We are going into our next session, and really would like to appreciate you for being with us and for being with us yesterday. I would like to mention that yesterday was very insightful. We were trending. HIC was trending, HIC 2002. So if you're tweeting, please go ahead, share, tag us at UNCDF Digital, tag the Academy, and let's keep the conversation going online and even here in the room. So I'm going to be calling very interesting discussants here, talk about one of the other solutions that we have been working on. And the topic is harnessing digital for sustainable community health service delivery. Yeah, it's a mouthful, but if you work in the health sector, I'm sure these are words that you've heard before. And to discuss that, I would like to invite Dr. Ochatri Ronald. A man I believe needs no introduction in the health space, but he is the Principal Strategic Health Communications Officer at the Ministry of Health. Dr. Ochatri, please join me here on the stage. I'd like to also invite Brian Senoga, who is a partnership specialist at Medic. Brian, you're welcome. And last but definitely not least, I will invite Andrew Akankwasa, who is an information technology lead at BRAC Uganda. Andrew, you're welcome. It was a well-balanced panel. We had Priscilla joining us from Living Goods, but she's not able to come due to something that came up abruptly. So we would like to mention that there are women that are doing a lot in the digital health space. This is not a reserve for men. Okay, so I'll just give a little bit of background about this. Many of us, we know that really community health workers are at the center of the work we do in the health system. The role that they play cannot be overemphasized. They're the ones that we interact with at the local level, and they do most of this work on a voluntary basis. So the challenges that they face, you work in the health sector, most of you know the challenges that are there in the communities. And so as UNCDF, with our partners BRAC and Medic, we did a study and assessed some of the challenges that they face, especially in doing their work, in easing their work. I would like to mention that this project really specifically addressed particular challenges, as you'll hear. There's so much more that we can do, and that is why we share this in the different forums, so that whoever wants to contribute or is able to contribute can also be a part of this. But really, you've heard a lot about ECHIS, and if you're not in the health sector like me, maybe you're probably wondering what is that and what does it mean for the health sector. So to shed more light on this and to really put it in context, I'll invite Dr. Ochatli to tell us about the perspective of ECHIS from the ministry's point of view. Dr. Ochatli, you're welcome. I would like to request that we put our presentation up, please. Thank you.
Thank you very much. Distinguished. Okay. Thank you very much, Rachel. Distinguished ladies and gentlemen, it's a pleasure to be here this morning to discuss about the work that we have been doing together with our partners in as far as offering healthcare services, specifically the issue of electronic community health information system that Ministry of Health is now moving into. As already introduced, my name is Ronald Miriam Chatre. I work with the Ministry of Health. Specifically, I oversee the issue of community health workforce in the ministry, apart from other activities that I am I'm expected to do. And I'll be very grateful to present to you exactly what we have been doing with our partners. And I hope by the end of this all, we would be able to have a good insight into this. Maybe just to start with, it will probably be good for us to know the indices or what this country is working towards. You know, we have a population of close to 46 million. And of that, we have about 25% who are urbanized. And of course, this is increasingly growing up. And our maternal mortality ratio has come down a little bit to 336, but this is definitely not good to talk about, because definitely nobody wants to see any mother dying because of giving birth. We would like to come to zero, but we are on that journey. It is a figure which came right from over 500 per 1,000 live births, and we are now about 300. Hopefully, in the next assessment of our Uganda Demographic and Health Survey results, would probably be talking about a figure much less than that. The infant mortality ratio is also not anything to celebrate. You can see the figures there. And when you talk about infectious disease risks, it's very high as a country. And I'm sure for those of you who are out of this country may realize that right now we are grappling with one of the most dangerous epidemics, and that is Ebola. But the good news is that we are actually now on top of the game, but that doesn't give us reason to celebrate. We still need to be on the lookout because we can't be sure, because our boundaries are very porous, and therefore we need to be on the lookout all the time. Importantly is the issue of mobile phone subscription. You can see we have about 61%. Why we are giving you this is because eventually we want to justify and think why we are talking about digitalization. And then the internet use is 12 million. Internet penetration is still about 26%. Oh, am I going downwards? Oh. The green one? Okay. You know, learning doesn't stop. Eh? Yeah. As a ministry, probably it is important for you to know our vision, our mission. As a ministry, we stand for responsive, resilient, and people-centered health systems that protects and promotes health and well-being of the people of Uganda. And that's what we always work towards. And we would like to promote and ensure universal health coverage in Uganda through evidence-based and technologically sound policies, standards, and strategies that are client-centered. And this conference is one that is actually working towards our mission. We don't want to leave anybody behind. We want to use technologies to see how best we can be able to offer quality health care services. If you look at our community health service delivery, you realize that the community health workers in this country are doing quite a tremendous job. And we think that looking at our disease trends and patterns, you realize that majority of them, over 75% of the diseases and conditions that we see are actually preventable, and preventable by just effective and correct communication. And therefore, we think by having this structure at the lowest level possible in the villages, at the households, at the parishes, we should be able to, in a way, prevent some of the conditions and diseases that can be preventable and only leave those that cannot to the healthcare workers. So that in the end will go a long way in lifting up the burden on the health workforce. But we know to achieve this, there needs to be a lot of initial investment, and that's what we are looking towards. I was seeing the innovation of the drone. Actually, down there, I was saying, I think we are really moving in the correct direction. But again, the question is, although the costing was a little bit minute and we couldn't see the costs involved, I know the initial investment must be heavy. And that is the cost of trying to make sure we offer quality healthcare services. And the same is in the area of community health space. So we want to work towards this and ensure that we invest in this area. And when we invest in this area, we are very certain that in the long run, there will be return on investment. So if you look at what these community health workers are doing, we are looking at issues of disease prevention and immunization promotion, because if you talk about immunization services, you are talking about covering more than half of the population. You are talking about the under fives, you are talking about the mothers, you are talking about the young girls. So we are basically talking about more than half of the population. That's what we want to promote. These fellows are equally involved in maternal and health, family planning services, assessment of under fives, especially in the communities, specifically through our ICCM integrated community case management activities, where we allow the community health workers to be able to offer some basic services for malaria, for cough, pneumonia, if you want, for diarrhea. These are the things that are actually increasingly causing ill health amongst the children under 5. So these are services that we think these community health workers can be able to offer. The issue of follow-up, whether clients who are on ARTs, those who are doing, who are on treatment for tuberculosis, and then the issue of newborn care, ensuring that these mothers who have given birth newly are encouraged to go to facilities as and when they give birth, especially for the issues for the services of postnatal care and having the children checked regularly. These are some of the things that are being done at our community level. And the issues of basic medical treatments, specifically for some programs. I'm sure we have a number of programs in different regions. For example, treatment for trachoma, which is in the eastern part of this country, treatment for filariasis, which is in some parts of this country, like in northern Uganda, and then also schistosomiasis treatment in areas where these diseases are. So these are basic medicines that we entrust with our community health workers and allow them to offer these services, which should have been squarely offered by health workers, but because of the shortages of health workforce, we think at that level, they should be able to help us offer these services. What you see in front of you is just the hierarchy of how our structures are working. Basically, the community health workforce we have in this country right now, we have what we call the village health teams. But of course, the ministry is also in advanced stages to introduce another layer, the community health extension workers. Right now, we have already piloted. We are piloting actually in 2 districts of Mayuge and Lira, and we are trying to control in Kabarole and Chotera. Possibly after 1 year, we'll be able to do some learnings and see how effective they are, whether the country can think about scale up. And we think that in itself is good enough to add layers of community structures that should be able to advance our causes at that level. So this structure you see here is depicting how our structures of working with the communities is. From the household level, you realize the households form a village, then these villages, of course, form parishes, sub-counties, and then up to the county and district. So we have VHTs who are in charge of villages, and they are taking care of a number of households. Ideally, we think a VHT should be able to take care of up to about 150 households. But practically, we have realized in some parts of this country, you find a VHT actually takes care of over 200 households, even sometimes in Wakiso here, 300. And that in itself, although workload is much, we need to find a way of lessening this work, because these are squarely volunteer workers. A volunteer in the real sense of voluntarism, the African one. The African voluntarism is 100% free. But I know from other perspectives, I'm sure my friend Dr. Rose, who is here, when we talk about volunteers, her perspective of volunteers will definitely be different. And that's the reality. So these are people who have to do something to fend for themselves. They have to do this work to be able to promote health. And ultimately, we must make sure their work is lessened. And that's exactly why CHAI is going to be a very important thing for us. So from that level, we have a layer at the parish level who are supervising the ones at the village. We then have another layer at the sub-county level where we have now our professional healthcare workers who are either environmental staff, the health educators, they are nurses, they are clinical officers, depending on what the district has available to be able to supervise them, then information flow to the district and ultimately to us at the ministry. And this for us is important because we want to generate and have information. And this information from the village should be able to be delivered at the parish level where we have a coordinator. And that fits so well with now the idea of Ministry of Health wanting to have community health extension workers at the parish level. Fellows who are community health workers, yes, who are better trained, yes, and who would be able to have the capacity to supervise the ones at the villages. So that in itself will mean that they will be able to help us get this information and then relay it to the supervising facility for onward submission to the district, and then finally to the Department of Health Information, where we can now take actions. So that is what we think needs to be done. So what are the community health service delivery bottlenecks? I want to give you the service delivery bottlenecks because I'm trying to justify a reason why we should be thinking about investing in ECHIS. Targeting and following up is a big challenge because VSTs have to look for households on pages of registers. You know, we are still on the analog system where we are doing paper-based reporting and a very big registers for those of you who have seen them. So somebody has to sit down and fill all this information. Remember, this is voluntary, and remember, this one has a family. So it's difficult to trace, and therefore need for follow-up is a big challenge. Management of bulky papers, having to move significant distances to submit reports, and then also the nature of the forms for reporting. Those are all big challenges that need to be, okay. Yeah, that needs to be addressed. And this, I think, we think is not worth it. There are issues of quality of data based on the quality of the people that we are involving. And that in itself is a big challenge as well. So why I'm giving you this is you must understand the background where we are coming from in terms of the challenges we have and what we would really want to address. And then the objective of digitalization is really to implement a digital job aid for community health workers with reporting as a perspective, as a passive process. Specifically, we want to ensure appropriate governance framework for community health information system. Then we want to aggregate functionality, then the different programs and functional specific digital tools into single government-owned digital community health information system, because we have a system, and we want the other systems to be aligned with what we have. So that therefore brings me to the end of my presentation. But just to let you know that as a ministry, we are in the process of ensuring that we make work easy for the community health workers to be able to report what is happening at the community level, because it is at that level that we want information for real, real-time information for action, which we can be able to, at this level, at the various levels, even at the district level, to take. So I want to thank you very much for listening, and allow me to stop here. And if there are any issues, we'll respond to them later. Thank you.
Thank you so much, Dr. Ochatri. I'm going to invite Brian to now talk about the technology that was deployed in northern Uganda. Thank you, Brian.
Good morning, everyone. My name is Brian Sanoga, and I work with MEDIC as a partnership specialist. My job is to create relationships with partners that help us to do the work that we're doing. Okay, our friend is acting up. So in support of this work, in late 2019, we started this conversation with UNCDF to try and ask the question, could there be viability for digitization for community health workers? And is this possible? And if it was possible, what kind of environment would we create? The first thing we did was to address the question of understanding the bottlenecks and the solutions. This is a WHO framework that helps to give a lens or give a definition to how a digital health intervention might be addressed. So you're thinking about whether your digital intervention, what it can do for clients, what it can do for healthcare providers, what it can do for health system managers, many of them who Dr. Ochatri has explained, but also being digital, the data services. This framework is globally recognized, and I would encourage anyone who is building a digital tool to work in the health sector to use this framework to evaluate your platform. It really helps to tell. designing any digital solution, or indeed designing anything for especially health, requires that you have a very grounded understanding of human-centered design. We do not start with technology. We actually start with people. We really want to understand what is the issue, what is the problem. As Dr. Chatri has explained, we want to really look at that big book, the red register, that VHTs carry around. And we really want to sit with them and understand what it takes for them to do this work. What does it really take for you if you have 4 hours in a day to look after 60 households and all the children who are below 5 in those homes? And we want to make sure that when we bring digitization into this framework, we haven't just sat in a dark room and thought about what we think is cool. We've actually come to the field and explored what the tools say. And so we do a lot of human-centered design in this work to make sure that the tools will match the standards that we're expecting. We build for the right people. So we want to understand not just the community health workers, but everyone who is in the healthcare chain that will be involved, either in supporting or supervising the community health worker, or indeed using the data and the output of their work. Each of these personas is a part of the digitization. And so you're not building a tool for just one, you're building for the ecosystem. When it comes to healthcare workflows, your understanding, as Dr. Chatri has told us, they're doing newborn care, they're looking after pregnant women, they're looking after children under 5. So what we've done is we've taken all of these workflows and created what we call an integrated platform. And so when a community health worker uses the ECHIS to register a pregnant woman, that registration will actually follow through all the way to the birth of a child and to the immunization of that child and to all the 2 years that are required for immunization to be successful for children. By understanding the different care workflows and how they connect, you can use Digito to bring them to life in an integrated way. And for a community health worker, they get to hold only one device and do one simple job, which is to continue to provide care at the household. So what are the features that are in the Community Health Toolkit, which is the platform that has been adapted for the National Community Health Information System? The first and most important is longitudinal profiles, which means a community health worker or the VHT only gets to register a household or an individual once. It does not matter that that child will grow and have multiple birthdays, they'll be registered once. The platform will have the capability to recognize and see this individual because it is exactly how they would be if they were doing it on paper. They would not register you 10,000 times. And so we do that. And this allows the registration to not only be about the individual, but individuals can be placed in a home, in a household. So the app has both an individual view and a household view. And this is important for the information being organized in a way that makes sense for community health workers. The second feature is care guides. A lot of our VHTs actually have not done so much formal education, significantly higher levels, but they understand what it means to give care to the community, and they've been entrusted by their communities to provide this care. However, we can add value to what they do by bringing care guides such as pre-referral treatment or the logic around how to mix ORS using basic ingredients. By bringing that as a guide into the app, you strengthen what the VHT is able to do. You add value to their work. We create workflows around diarrhea, pneumonia, malaria. It's not just high temperature. It's not just high fever. It's going from the basics of high temperature to an MRDT to definitely verify that this child is testing positive for malaria. The third, and I love this feature because every one of us here who has a smartphone uses your calendar, all right? You set your own appointments. When you start the day, you have an idea what you're going to do. We've taken some of that logic and built it into the app for VHTs. It's called Tasks. It's for schedule management. When a VHT starts their day, there's a consideration they need to make. If I'm only going to volunteer for 4 hours today, which home do I need to go to first? And which action do I need to complete first? And so the app uses the task bar to bring to the top tasks that are due today. And so the VHTs, all 1,700 of them now, they start their day with an idea about where to go. In other words, which home do I go to today? But most importantly, which action am I going to complete first today? And that's a game changer because we use some of these analytics to track speed of care. How quickly did a VHT reach the child or a mother who had symptoms for care? And then the last one that I want to highlight is data use. We always have treated digital and a lot of digital interventions to serve the purpose of reporting. We've always built this work so that we integrate into the next national report. One of the things we wanted to change was, could we bring data use down to the VHT? And so there's a tab in the app. It's called in-app analytics. And what a VHT will find here is every day they're going to find numbers that represent the effort of their work. This tab is going to tell them some all-time numbers, for example, all the homes you have ever registered, but it's also going to tell them some monthly numbers that refresh every 30 days. For example, newborn visits, this month. By bringing data use down to a VHT, even though we think that they're not educated, they really start to appreciate this new lens of their work. And for us, the educated guys, the health system managers, people like Dr. Ochatri, we can lift the rest of the data, aggregate it, and bring it up onto national dashboards. And that will allow us to make decisions that are for us as health system managers, but for a VHT, every single day that they go to work, in-app analytics gives them a sense, an appreciation, an understanding that their effort is recognized. Obviously, if you're going to build a platform and you're going to make it a national platform, you need to think about how to not live in a bubble. The community health information system is built for interoperability. A lot of us talk about integration. Integration is the language that we've been trained, especially in school. But integrations quickly become expensive because you're achieving a one-to-one connection. The conversations in innovating for digital health have taken the next step, which is interoperability. We're not just saying, let my app connect to yours. We're saying, can we build apps with global standards? Can we ensure that what our applications know to do, how to collect personal data, is a shared global standard? Because then it doesn't matter if my app is connected to yours. If we all collect first name as first name, it means that we can all share data. We can share insights with each other. And so it's not just platforms like Rapid Pro and DHIS2. We want to connect into EMRs. We want to be able to lift the data that we have at the community and connect it to the facility and enrich the record that facility has about the individual. This is important for us to do. The Community Health Toolkit is just a platform. The application, Community Health Information System, is simply an app we have adapted on this platform. The platform is a digital public good. It's not just software that you're just going to find on a repo. Yes, we've made sure on the GitHub repo, everyone can access the software because it's a digital public good. But we've also made sure that there are resources. And so there's a forum that supports this work. We've made sure that there's a community of implementers. And so the next time you want to learn about the CHT, you don't have to look for Brian. Although it would be good if you picked up a call and called me. I'd like to say hi, but you really do not need to talk to Brian. There is a community of implementers that extends around the world that understands how to use CHT. Within the bucket of digital public goods, we're able to say, not just to the government of Uganda and to partners like UNCDF, but to the whole innovator community, that it is possible to harness digital solutions for healthcare. And I'll stop here and invite Andrew, who is a project lead at BRAC, who was directly overseeing the work in West Nile, to continue. Thank you.
As Andrew is going to the podium, I would like to mention that the data that you saw there is dummy data, so we do not show patient data. And yeah, just so that is clear. Thank you.
Morning, everyone. I'm called Andrew Kankwasa, and I work with BRAC. BRAC, I know most people when they hear BRAC, they think about the bank, but the NGO. We have two wings, Okay. So I'm here to talk about a project which is running in West Nile and in northern Uganda. That in West Nile, that is 3 districts: Koboko, Maracha, Nebi, and in the north, we are talking about Lira. And the project is for 3.5 years. So 2023, we shall be starting our last year. And the purpose, I think most of the things have been talked about, but the purpose is support the government of Uganda in digitizing the community health programs with the electronic community health information system. That is the ECHS in full. And the objectives of the project were, one is, I'll begin with the second one, to improve delivery of community-based health services, such as antenatal, postnatal, immunization, reproductive health services, case reporting, and performance tracking. Why I'm beginning with the second one is the tool is not just about data collection. It is for implementation, like it helps you in assessing. Then the second one is to empower the community health workers to collect real-time data on the key ministry of health. So those are the two main objectives. We know very well that the VHTs, those or the community health workers, their level of education is actually for selection, for it to be selected as a VHT, it's about just knowing how to read and write. And we're looking at these workflows, which are so many. So the application helps you to go through all those workflows without forgetting anything. And the third objective is to improve the motivation and performance of the VHTs by establishing a sustainable financial inclusion mechanism in collaboration with the BRAC Bank. What I mean here is the VHTs, Dr. Chetri talked about it, they are volunteers. They're not being paid. So as the project we thought through it and like, how can they be motivated to work as much as they are volunteers? That's when we came with this idea. Let's do, actually it is about bringing the products to them, health products to the VHTs at a cost price. So that when they sell at a margin, that margin remains for them. In so doing, they earn something as they are volunteers, but at least they go home with something. And the journey for the project, we started with the project inception, went through the baseline assessment, then human-centered design, which Brian talked about, user acceptance testing. All the workflows were tested at the lowest level, even with the VHTs involved. And then we went to, from the the UAT, then they designed the application. And along the way, we have started using the application already, and people are appreciating it. And we have even gotten some feedback, because it has to keep modifying. This needs to be changed, and we've been working on all that. So then the deployment happened. And this deployment happened actually in phases. We first had 3 districts, that is Maracha, Nebi, Koboko, and recently we did also Lira. So meaning all our 400 VHTs are well equipped with the smartphones. And in those districts, as you can see, like Koboko has 11 sub-counties, but out of those 11 sub-counties, only selected 4. And even those 4 are not fully covered because the project came as a pilot because it was something new in the space. So wanted to first test and see how do these people perceive the new innovation. So now, like for Koboko, we have 4 sub-counties. We had to look for the rural setting, the urban setting, and even the refugee setting to see how does each receive the tool. Okay, thank you. And good enough, along the way as we were progressing, we have come to realize that everyone in all the environments, it has been a success and has worked fully. So that's why when we came to Lira, which came in as the last, we didn't go like we are piloting. We now took over the whole sub-county so that we can have the lowest level of entry in DHIS2 is the facility. And so here we had to take all the VHTs at the facility so that even if you want to go and download, or you go on the dashboard, you download the data, it is complete. You can just transfer it to DHIS2. So that's how we did it. And along the way, we have registered 24,529 households so far. And the population is 120,071. Then households visited for the last quarter is 20,668. The achievements to date, like I talked about, all the 400 VHTs are now well equipped with the smartphones and they know how to work with it and report. And the approach, the trainer of trainers approach has established local capacity, continuous support, change management, and provision of first line technical support in each of the districts. What I'm talking about this, the TOT is, as the project, we are very few people on the project, but we maintain the same structure of government. In this line, we have, because there's a VHT, the supervisor of the VHT is the health assistant, then there is the DHE. So we maintain the same line. And for sustainability, we try to maintain the same structure and we're only just empowering them. And good enough, even to the parish level, these parish coordinators are even able to do some troubleshooting on the phones. Supposing one of the VHT's application is out, they can be able to install. That is the level we have taken these people to. And we have also improved the target service delivery through the task reminders, which Brian talked about. So that when you have 100 households and you have all these ladies who are among them, it's not easy to track each and everyone. We know they do ANC, PNC, but if you're going to do it manually, it is not easy. But with the phone, every day you wake up, you just go on the application, on the tasks, and you see, what am I supposed to do today? Then you will see the number of the people whom you're supposed to follow up that very day. So it is easy for you to come and say, let me call this person, let me go and see the other client, let me go and see the other client. And at the end of the day, you find at least you're managing everyone. And the other one is improved evidence-based decision and support making through the real-time view of the dashboards. What I mean here is we look at the health assistants. The health assistants have over 100, they support over 100 VHTs. And with the limited resources, you cannot just say that I'm going to go to every VHT and see how they're working. But with this, with the dashboards we have, it is easy for you to just come and go on the dashboard and look at who is lagging behind. If we're looking at assessments, which person has not done any assessments, which is different from the other time where you would just come at the time of collecting the reports, and that's when you find someone has not reported. Then we have improved commodity tracking, shine a light on machines and materials, medicines, sorry, and materials at the community level. So in the application, we also have a consumption log. So at the beginning of the month, you do a stock count of the medicines that you have, and you enter them in the application. So along the way, you'll do a treatment. If you do a treatment, let's say you've done a treatment of malaria, the ACT will reduce. If you had 10 doses, now there will be 9. If you had, so along the way until the end of the month, meaning at the end of the month, you will find the closing stock that you're supposed to have. And we also have, when we talked about the financial inclusion, we did the financial literacy training at the beginning for all the 400 VHTs. And all these 400 VHTs, after taking them through the financial literacy, 80%, 85% of them voluntarily came and said, I need to open a bank account, which was a very good plus there. Some of the challenges we have faced is being a pilot. You see, I told you how we are trying to target different areas to see. The coverage is not that large. So when we're looking at the reporting, where the reporting is the lowest level is at a facility, and we're not there for the other 3 districts, it comes with a, like, it doesn't, the reporting is not fully. Then the district maturity, from resources to staffing to infrastructure, it takes more than good technology to sustain a digital intervention. Then hardware challenges. These were expected even at the start. The loss, the damage, and the misuse of hardware provided to the VHTs and the supervisors. And when we come to, and this for sustainability, we have to think about all this. So for the damage and loss, we are looking at creating a platform where we can always, for now we are repairing the phones for them, but moving forward, how can we handle it? And for the losses, we have not had so much. Actually, the good thing is that there has been a lot of community involvement in this. I remember there's a time when recently we had a phone loss in Lira. After having that phone loss, and when they came to tell us, we said, first file a police report. But during that whole process, the chairman called for a meeting. I don't know how it happened, but the phone appeared again. So meaning the VHT, the whole community is involved in the safeguarding of the phones. Commodities and materials stock out, that is one of the biggest challenge, stock out of ICCM commodities. Because when we're talking about assessments and treatments, you will not do a treatment if you don't have these ICCM commodities. So it's a challenge. But for now, what we tell them is, if you don't have the drugs, at least you can continue with these are the MCH, the ANC, the MCH, the postnatal, and also the lack of PPEs, compromised fulfillment of the VHT tasks, and lack of other necessary tools like mark tapes for nutrition assessments, which are very vital. Then success stories we have received so far. We have a VHT called Robert Telechan from NEBI testified that from the revolving fund we're talking about, where you buy some products at a cost price and then you can sell and earn something. He testified that he was able to put up a 2-roomed house from the profits. That's how far it can go. Then we have another one from Koboko, that is Yosa Isaac, also mentioning that currently with the financial inclusion, he never lacks any 20,000 at least a note, which used not to be the case. Lessons learned, we have learned a lot. Government leadership is key for ownership and sustainability. The same thing with even the community, which I talked about. If the community is involved, then the project becomes easy to implement. Partner mapping, harmonization, and involvement is critical. Human-centered design approach is critical. Brian, which talked about, if you're going to design a tool like this one, which involves very many stakeholders, they all have to be at the forefront. Like as you're starting, involve them at the start. Implementation approach, phased implementation and rollout allows for gathering lessons for system refinement, improvement, and scaling. Capacity building for both national, district, and health facility teams is vital. Since we're going to be using the same structure of government, all of them need to be well-oriented on the tools. And then the continuous refresher trainings for community health workers. We know, like I talked about the level, these people, these are old women and men, and they always forget. So we always have to do the refreshers for them to keep on track. And then we have the device management, alternative power sources like solars are necessary for areas with limited access to electricity. And then need for a device management system and policies for better management of these devices at all levels, because they are very much expensive. If we're losing them at a high level, at a high rate, it's a problem. So there needs to be that one that we have already learned about it, and it's already ongoing, the device management. And then CHW cost sharing in mobile device repairs and maintenance creates a sense of ownership and responsibility for sustainability. With that, thank you for listening.
I don't know if we have time for one or two questions. Dr. Martin, you can let me know. Do you have time for one question? Yes, asking if we have time for one more question. If we have time for one or two questions, we're able to take that. We are standing well in between your break. So if you have a burning question, you can always reach out to the presenters here. But if you have a burning question, not the mic. Let's answer two questions, then we take a break. Thank you.
Yes, thank you to the presenters. Mine is just a simple question. So what criteria was used to, to select the districts of, Maracha, Koboko, Lira, and Nebi? Because if this is a pilot in those areas, and I assume it's going to be rolled out to the other parts of the country, is that right? So, and keeping in mind that the different populations have different, demographic characteristics. So what works in Maracha might not work in Kabale, or are there plans, to have subsequent pilots in all the other areas? Thank you.
Do you have another question?
One more here. I didn't see who put up their hand first. Okay, since there was no gender balance on the panel, I'm going to give it to this young lady.
All right, thank you so much. Mine is about confidentiality in the real life situation as you use these to keep the confidentiality and privacy of the patient's information. Thank you.
Thank you. Dr. Ochatli, do you like to take the question on why Maracha, Nebi, Lira, the whole country needs this solution?
Okay, thank you. The decision to go to those districts, specifically in the north, was arrived at based on a number of things. One, we have a number of partners that work with us, and we have zoned the country according to the different partners that work with us, especially in the health sector. And this innovative idea, which was brought by BRAC, together with the Medic Mobile, and of course with support from UNCDF, when it came up, we sat as a ministry, and in our technical working group, we agreed that yes, this is a good idea to innovate, but the decision of where they would have gone was based squarely on their area of operation. We've zoned districts, and the partners have been given different districts where they operate. So we thought to make work easy for them, would rather, instead of stretching them, would rather allow them to be in an area where they are already operating and having other activities, so that it is cost effective. Of course, it would have been good to possibly say, let's do one in the east, let's do one in the west, let's do one in the central, like that. But this was not the case. we thought if we had a learning from those districts, VHTs have been VHTs, and there is no difference between what they do and what the others will do anyway. So we thought if the VHTs in one part of in those districts where they are can be able to master this digital application and report, then we can actually be able to scale it up. It's not like something that will probably need okay, there are issues of cultural sensitivity, yes, but this may not be so much applicable to this particular area because we're talking about digitalization, we're talking about involvement of community structures, the VSCs. So whatever we learn in one district, probably think can apply in others. So that was the basis on which the ministry thought, let's go to where they have been working. Let's see if you can have lessons learned. And surely we've learned lessons, and I can assure you we are going to scale up. Thank you.
Yeah. Thank you, Dr. Ochatli. And permit me to mention that, as Richard mentioned earlier, really UNCDF's strategy is to leave no one behind in the digital era. And if you understand, like in this country, we know that the North has been left behind a lot. And that is why some of the funding was actually tied to that region. And also because we are here sharing the lessons, and UNCDF really works as a market facilitator. So we open up markets for the different players to step in. And that is why we are asking you, come in, support this, let us scale it to the whole country. That is our cry, that is something that will really make us happy. But I will ask Brian, I can't look at you because the microphone is here, but can you talk about client confidentiality? How do you maintain that? And we have 2 minutes to answer that question before we go for a break. Thank you.
Thanks. So if you are a VHT and you were previously working and you did not have a smartphone, you'd have a big red book called a register. And everyone's health information would actually be in that book. And so if you think about what level of confidentiality that would look like, that's really the place where we start. However, when you digitize the ecosystem, then you start to think about, first of all, what am I going to do with this information? I'm going to put it on the phone. So you start with role-based access. So every VHT has an account on the national system that is not their neighbor's account, that is not their supervisor's account. Everyone has their own account, okay? And so once you have that level, and then you say, okay, it is a smartphone, it can't be stolen. So what's the next level of security that I could deploy to protect the information? And so we have encryption on the phone. And so the app on the phone could literally be wiped without, if the phone was reported as stolen. And then you say, okay, so the VHT is going to sync this data. It means their device is going to push it to a cloud server. So what's going to happen as the data moves? So we encrypt in transmission, okay? And then at the server, again, is another point of security concern. So we actually store the data in a cloud database that is no relation. So for those of you who are familiar with CouchDB, that means that you have documents that are coming from all the VHT's phones that cannot be deciphered in and of themselves for the information they hold, until you actually write another script to convert that into relational data in, say, a Postgres database. Moreover, we've made sure that all of this is hosted at the Ministry of Health. And so we do not independently hold public sector data. We actually store this at the Ministry of Health. And so security and confidentiality is multi-layered. And as a developer, you need to think about all the different points of failure and how you can protect the health information. One final layer that we do is we actually do not take PII, personal identifying information, and take that onto any of the dashboards or analytic platforms. We actually take aggregates. So we visualize aggregate data of the community, not individual information. And so Think about that old big red register that a VHT has. That's the one place where he has a name and a phone number of Brian and all his children and whether they've been sick. And nowhere else is that information seen in the rest of the ecosystem, all the way up to DHIS2. And so we've done that in the app. Only on the VHT's phone, in their personal account, that's the only place you will find Brian and his children and everything else. Everything else beyond that, we have considered layers of security, certainly following data protection guidelines for the country.
Thank you, Brian, and thank you so much to our panelists, Dr. Oshatley, Brian, and Andrew. We're now going to take a break, a 30-minute break. Our panelists will still be with you. So if you have any questions, you can reach out to them directly, and let's keep learning from each other. If you have insights that can help, please share with us. But our next session will start at 12 p.m. And so we request that you really take a quick break, have your coffee, and be back for the final session before lunch. Thank you so much.
Here's how digital solutions are improving the education in modern Uganda.
But they don't have that. So you find that now in this application, that information has been sent very, very well. I think that it's great to the person on their big website. They are very out to manage the
Unity Health Workers, supervisors, and PhD.
Trained by BRAC to use the app to track cases in their community and refer cases that can be handled at the nearest health facility.
In the phone, they ask how old the person is, the child, and what sickness is the child is having. And we ask the parents how long the child has been sick. And even it is there in the phone.
In education, digital solutions are enabling people to pay school fees more conveniently.
Ever since we started using School Pay, we have had a reduction in our cost of operations, because before parents would come and pay fees in school. Then after paying the fees in school, they would after them paying fees, now we would have to start balancing books at the end of the day. Then you have to rush to the bank before 5 o'clock and have the payments. Then we had to employ one full person just in charge of writing fees, which is being brought to school. Parents are now taking fees through school pay and through more agent banking. So on that platform, on that area alone, we have saved about 2 million per term.
If I am using my motorbike, it takes me 3 hours serious riding from where from my home village. Serious riding, it is 3 hours. I must come all the way from that distance. And Access Bank, we have only in Lira here, the bank that we use. I come from a Leptong and I access the bank sometimes. I come late and I find bank is closed and I have to pay the cost of my living in town. Yet I've just come to pay school fees only. Then from there, the experience is that it delays me so much. But school pay is quick and you do it just right now and you receive the message back.
Check out our other videos to see how digital solutions are being used in other sectors. During the first decade of the HIV epidemic in Uganda, everyone was either infected or affected by the disease. It claimed lives, and many lost their parents, children, friends, and neighbors. However, HIV prevalence declined from 21% to 9.8% between 1991 and 1998. The country was hailed internationally for its efforts in reducing the spread of HIV/AIDS compared to other African states. This was especially through effective campaigns like promotion of abstinence and condom use while discouraging multiple sexual partners. Sadly, many young people today may be complacent about HIV as they have not lived through the years before medications were available, a time when AIDS was killing thousands of people each week. In 2018, the Academy for Health Innovation collaborated with Uganda AIDS Commission, TASO, the National Museum of Uganda, and other implementing partners to develop an exhibition detailing the journey of HIV response in Uganda. This was in an effort to document
Yeah, you can. How does this? This is the next. Thank you so much. Welcome back from the break. Thanks for keeping time. We are now going into our next session. But before we do that, I would like to mention in the presentation from BRAC, there was one of the success stories was VHT that has been able to build, construct a house. I was surprised to meet him at the door, and I would like to invite him to just say hello to us. Robert, if you're seated here, come and say hello. Maybe just tell us where you're from and the work that you do and how you're interacting with the digital solution. Thank you.
I would like to thank everyone. My name is Kershan Robert from Navy District, working as a VHT. On the digital system, UNCDF BRAC and MEDIC has helped us a lot in piloting the project. I'm also the district coordinator in that program. I always make sure that all the VHTs one in the program, whoever is having any challenge, come to me and we work on the issues which is disturbing them. So I'm glad to be here in Kampala and I'm happy to meet new friends. Thanks.
Thank you, Robert. Over to you, Esther, to take us through the next session.
Thank you very much, Rachel. Good morning, everybody, once again. We have just fed you. Good morning. How are we? Okay, thank you, please. Yes, so my name is Esther Shakira. I work with Rachel and Richard at UNCDF. I will be taking us through the next session. So allow me to give just a little introduction to the session before we start. UNCDF, together with our partners, Medical Access Uganda and Signalytic, have developed a solution, the S+ platform. It digitizes the stock management of essential drugs and medical supplies and is complementing the work that Ministry of Health is doing to improve access to essential medicines, and is currently being piloted at the parish level in Health Centers 2 and Health Center 2s and 3s in Kirinyaga district. The S+ platform aims to promote equity and quality of health services, as well as strengthen district monitoring and supervision processes. It is the digital backbone of the future, especially in the health sector. By leveraging internet and smartphone penetration in rural Uganda, the solution addresses the most prevalent challenges to digitalization in the health sector. These are hardware, cost, connectivity, and power. So I'll request that we turn our attention to the screen for a brief video from Signalytic, just breaking down how the S+ platform works. Tech team, do we have the video ready?
In an effort to support the pillars of digitizing stock management, supporting health facilities and reporting, and providing stock visibility throughout Uganda's health system, in 2018, a team of researchers conducted a human-centered design research study to explore the bottlenecks resulting in chronic shortages of medicines in lower-level rural health centers in Uganda. The study illustrated that the problem did not stem from a lack of digital solutions, but from the points of failure that conventional hardware such as computers, mobile phones, and tablets had in low-resource contexts. Where attempts have been made to introduce digital stock management systems, constraints such as unreliable electricity, high operational costs, and poor network coverage rendered such hardware powerless in the typical rural health facility. This resulted in failed attempts to implement digital systems, which in turn resulted in lack of system uptime, lack of data visibility, and life-threatening commodity shortages. A team of medical device engineers in Vancouver, Canada, took the findings as direct inputs and designed and built a first-of-its-kind hardware platform made specifically for the Ugandan health system. The Signalytic platform thrives in the typical environment of the lower-level rural health facility in Uganda. Built for efficiency and cost reduction, it can run on solar power and is able to connect health facilities regardless of internet availability. The partnership with Medical Access Uganda brings on board over 20 years of developing sustainable healthcare supply chain management solutions, harnessing the power of real-time vertical and horizontal visibility and early warning capabilities. To illustrate how this will work, let's take a look at a typical rural public health facility in Uganda. Other health centers of this level, this typical healthcare facility experiences unreliable power and network connectivity. Healthcare workers within the health center balance paper and digital reporting, often having to duplicate their workflows. Let's see how the Signalytic and Medical Access solution could work in this context. The first point of deployment of the Signalytic platform will be in the health facility's main store, where health workers must manage multiple types of inventory and handle requisitions from the health center's wards, as well as other health centers. With the Signalytic solution, the healthcare worker will have access to a single-purpose terminal, which acts as a dedicated access point to the health worker's digital workflows. As can be seen, the tablet's interface centers around the health worker's workflow and is designated to provide an action-oriented layout with clear task lists and pending items. Through this simpler workflow, the store manager is able to perform stock card management and fulfill and create requisitions for movement of commodities in and out of the store. All the while, data inputted by the healthcare worker to the digital stock cards is used to generate complete automated reports, which are sent to relevant departments and stakeholders. Elsewhere in the facility, other users are able to use the dedicated terminals for other functions. In this example, a facility in charge will be able to authorize requisitions, access and create reports, and create digital orders for commodities from the national medical stores. In future, the Signalytic platform will be able to host multiple digital solutions which are already in use in the Ugandan healthcare system. As such, the Signalytic terminals become a singular, dedicated space where healthcare workers are able to perform all clinical and administrative workflows in a fast, streamlined experience reminiscent of an urban healthcare facility with broadband internet access and constant electricity. The Signalytic microserver runs local instances of the various applications it hosts and connects to the terminals by creating a local Wi-Fi network. This allows for communication between wards with the health facility and facilitates internal coordination. The Signalytic platform has been designed for optimal performance in Uganda's lower-level health centers. Within the district, the Signalytic platform connects the necessary users in order to safely perform commodity management according to the guidelines and regulations of the Uganda Ministry of Health. At the district health office, district health administrators are able to access and use the Signalytic platform. A dashboard allows the district administrators to get various views on the status of the commodities within the district. In this example, a map-based view allows the administrator to review requisitions for redistributions of medicines between health facilities. At the district health office, users are able to authorize requisitions from health facilities, reports can automatically be uploaded to national databases, and commodity statuses can be visualized in various views such as maps and lists. This is also where system and user access controls can be modified. Across the district, health facilities and administrative offices share an identical copy of records through a distributed ledger technology network known as the DLT. Communication between facilities occurs through the Signalytic microservers and can happen through 2G or GPRS signal. In the future, the system can be optimized to operate using alternative communication technologies such as digital radio and microwave in order to access those facilities with no network reception whatsoever. The DLT brings the Ugandan health system into the future. It confers world-class security features and immutability of records. Redundant storage ensures information is not lost in the event of a server is out of commission. It can store any type of data required by any digital solution brought online in the future. And most importantly, it can do all of this on slow, interrupted network availability. On a regional and national scale, district information networks are organized in networks of networks, allowing the flow of information vertically and horizontally. The network of networks aggregates information and provides an internet-connected portal which can be accessed by national-level stakeholders. Data collected from the lowest level of health centers can seamlessly be inserted into the databases used by stakeholders for data-driven decision-making. In the medium term, the Signalytic platform will facilitate remote digital ordering of commodities by lower-level health facilities from central stores, providing up-to-date information and high-quality granular data for remote facilities, which has not been digitally captured to this day. This project has been made possible by the United Nations Capital Development Fund.
Yes, thank you very much to Signalytic in absentia for that detailed breakdown. As you can see from the video, this S+ solution is in fact providing a solution to those 4 major elements of hardware, cost, connectivity, and power. Now, allow me to invite representatives from Medical Access who are in the room with us. They're going to give us some more context to the ways in which S+ is being piloted and is actually working in Kiryandongo district. I will start with Peace. Peace Otaje is a software engineer and digital health futurist. I like that word. She's going to explain what it actually means. Who explores the convergence of emerging technologies to see how they can be adapted to digital health in the low and middle income countries in Africa and Asia. Let's give Peace a round of applause as she comes out. I will also be hosting Dennis Katerega. He is currently the manager of information systems with Medical Access Uganda Limited. A round of applause for him as well. So let me shift here so we can have a good flow of convo. All right. Yes, a warm welcome to both of you. Thank you so much for joining us today. So, Peace, I think. All right, just those technical issues. Peace, I think we'll start with you. Tell us a little bit more about S+, the technology that it uses and what the journey has been like in Kiryandongo.
So thank you so much, Esther. It's a pleasure to be here with you all. Esther asked an interesting question. She asked me what a digital futurist is. And I'd like to explain that first and foremost by saying in this era that we live in today, it's a bit difficult to decouple technology from our daily lives. And in a way, each of us is a digital futurist. A digital futurist, or I'd like to say, or what I'd like to call digital enthusiast, is just being able to understand future trends of technology and how the effects of dissemination of that technology impacts our local context. Particularly here in a third world nation like Uganda, it's important to see how technology trends can be used to better the outcomes of livelihoods within our communities, not just in the central, but particularly in rural areas. So back to your question, Esther, I'd like to give you a preview of the journey that we've had in implementation of the S+ solution. But before I do that, I think I cannot decouple minus beginning to speak about the partners that have made this implementation a success. As Esther mentioned, I am part of the team at Medical Access. Medical Access is a not-for-profit organization with 20 years of experience under its belt in implementation of supply chain services for pharma and health commodity products, including but not limited to ART, opportunistic infections, lab, as well as SMC. In addition to that, Medical Access also does provide technical assistance in design, implementation, and improvement of health systems throughout Asia, Africa, as well as some aspects of Europe. So we also partnered with Signalytic. Signalytic is the fourth industrial revolution or tech firm that builds medical devices, particularly fit for rural setup with challenges as was shown in the video. Their approach to this is primarily around user-centered design and leveraging already existing technology to integrate. We do not believe as a partnership into just wiping out what's already present. We believe in building on what is available and making it better. In terms of the partnerships that Signalytic has, through implementation of this and other projects, they have also made some good strides with USAID, MSH Path, as well as the National Research Council of the Government of Canada. So I would like to paint you a picture before I begin the story of how we came to work in Kiryandongo. I would like to take you with me on a journey to imagine yourselves in the context of a rural setting, having a pregnant mother, having just delivered and suffering from postpartum hemorrhage, which is the leading cause of maternal mortality worldwide, taking a life every 4 minutes. The complication can be provided by medicines. However, the healthcare worker is out of stock of this medication and doesn't know where the nearest health facility they can access this medicine in a timely manner to save the mother is. What is the solution? The solution lies around providing digital health infrastructure that thrives within a rural setting that would enable health workers such as this be able to monitor their stocks through things like fast expiry, fast out, ensure that there's easy distribution of medicines within the district, and ensure that we are able to avoid maternal deaths in that context. So with support from UNCDF, Medical Access and Signalytic back in 2020 came together to try and pilot a solution that would address these challenges at lower level health facilities, that's particularly Health Center 2 and 3. And we looked at doing this within Kiryandongo district. In terms of what our primary objectives were, we looked at improving inventory management and reporting. We also wanted to increase data visibility across the layers, as well as strengthen the capacity of health sector staff in planning and supply chain management. In terms of what we were able to reach through our pilot, we were able to reach 25 health centers. We piloted the system at all the sites, all the lower tier facilities in Kiryandongo. We were able to install at 8 health center 3s, 15 health center 2s, 1 district store, and a general hospital. So back to the context, we did not just want to innovate. We wanted to innovate with the purpose of fostering digital transformation. What is digital transformation, you might ask? It doesn't begin with innovating only. Building a system is the first step. We really wanted to be able to put something together that would provide operational efficiencies for the health workers and also be able to bring about a lasting change in the lives of the patients in terms of medicines access. So for our implementation methodology, we primarily focused on a 5-step process. The first one through implementation was being able to assess the needs of the terrain that we were operating in, what was required by the users, being able to configure a system that was not one size fits all, but would be customizable depending on the needs of the user group that we were targeting. Naturally deploying this through a phased manner approach to ensure that we were meeting the needs and quickly troubleshooting and turning around the time to allow easy adoption. We also utilized training through the train of trainer approach, we heavily relied on building communities of practice where we set up system champions with knowledge in the application and ensured that they were able to pass on this knowledge to their peers as and when required. And finally, continuous support provided to utilization of the system.
All right. Thanks a lot, Peace. Thanks. I think that was really great detail. You've spoken a little bit about innovation, not just for the sake of innovating, but as a catalyst for digital transformation. Do you want to speak a little bit more about how S+ has been that, especially for Kiriandongo? Dennis, you might also have some thoughts on that. Would love to hear from you as well.
Okay, so I'll go first and then I'll invite Dennis to pick up where I might have left off. So as you can imagine, as a first start, we did carry out a baseline assessment, and the purpose of this was to establish what the pain points of our lower tier health facility workers were in terms of digital infrastructure, digital literacy, as well as hardware and the like. So we carried out this baseline assessment to all the 25 sites as well as district store. This helped us come up with a roadmap and plan to be able to provide targeted solutions on how we would approach our innovation. Then, as you can imagine, COVID happened. So we had to go back to the drawing board and rework some of this to ensure that we were able to work through the period. We used technology for this. We carried out a number of design reviews and user acceptance sessions with store managers, not just here in Kampala, but also within Kiriandongo through Zoom, to ensure that we were capturing their workflows and actually our system would be able to address the challenges that they faced and would be easily adopted by them once we went into pilot. So following the user acceptance testing, we were able to carry out a pilot. Naturally, to have a successful pilot implementation, there is a very pivotal role of the different stakeholders. And so as a key point to fostering user adoption, we did engage with the district leadership within Kiriandongo, introduce them to the system and how it would benefit them. We also worked through the user reviews to capture their pain points, not just in access to data, but also visibility. And we also interface with the health facility in charges, implementing partners that support the region, as well as Ministry of Health officials, to ensure that what we were delivering was not just a solution that would help store managers at the most primal level, but would go up through the value chain to inform decision support, which is a key component of digital transformation. I will invite Dennis in case there's something I've missed out in that regard.
Thank you, Peace, for that presentation. Good afternoon, everyone. My name is Dennis Katerega. As I was introduced, I'm Manager Information Systems with Medical Access. So when you're talking about the challenges of digitizing inventory management in most of the facilities, especially at the lower tier, one of the challenges that comes up, these are the infrastructure challenges that come up. One being connectivity via internet, because we know most of the facilities we have in Uganda, connectivity penetration is a challenge that we all have. Then the other infrastructure challenge we face is again to do with power, because in most of these places, you can have power 3 days in a week, and then the other days you don't have it. So, and these are the challenges that have really impacted us having electronic systems in these facilities. So as demonstrated in the video, we want to see how the S+ solutions comes in to address those two infrastructure challenges. I need to first check how this is working. Okay. Okay, yes, I think I get it. So when you talk about the S+ system, one thing that comes to mind is that this is an integrated system. As you can see, we say it's a harmonized stack of system, because unlike the traditional systems, where you have to buy maybe your CPU as your computer, the software package separately. The S Plus comes as a combo, it's a package. It includes, if you look at the infographic there, you have the software, you have the hardware, you have connectivity and power all in one package. It's one solution that was designed to address these challenges. Then it was also built with the cost in mind. So unlike the traditional systems where you have to invest in the hardware, invest in the software in terms of buying the operating system, the Microsoft packages, all these costs are done away with. And also the hardware of the system itself is built to be resilient to operate in such remote and rural communities. The system also is self-reliant and also eliminates depending on external service provider, external expertise coming from foreign countries. We have an assembly plant here with the capacity and knowledge to build these systems. So we can always have support for this system as and when needed. The other requirement is that the system is able to integrate with any existing systems, because in the world we're in today, you can't have a system that stands alone. You need to have this communication across the systems. So the system is able to integrate with any existing systems. In terms of points of success, we want to look at the software. During the pilot phase in Chiandongo, this software that the users interface with, these are the stock managers, workers at the health facilities, the district health officers, they're all involved in the design and the requirements of the software. Because for any system to work, we have people, you have the process and the technology, and the three have to work together. So in the design, you had the users involved to ensure that their needs are catered for. And that was very important. Otherwise, if you don't do that, you get a point whereby you design a system that doesn't meet the needs of the users, and you fail to get the system running or it being adopted, because in one way or the other, it's not easy to use or does not comply with the process that people are going to use the system. Secondly, if you look at the hardware, as we said, is built to be low cost and also it's well spaced. And then also it's built and repaired locally. Like I said, you have the assembly plant here. So the hardware was built to really fit and thrive in such remote places, which the conventional systems will hardly struggle with in such an environment. In terms of connectivity, this is, I think most of you who are maybe worked with technology, you know that you need to have an infrastructure to have any systems work. Like you see here, we have some infrastructure that has been made for us to be able to speak and communicate. So in most of these rural communities, it will be hard to invest more in terms of cost, but also maintenance of such an infrastructure. So what S Plus system does is that it comes as a package. Within it has what we call the smart antennas. They're able to scan the slowest and the smallest signal available on any mobile network. So, and once it picks, most of these places we find they're operating on 2G, and 2G is a very usable network, because right now here, I think in Kampala, we all operate at 4G, which allows you to share images, information. So 2Gs can barely work with that network. But this technology has been consolidated and optimized to efficiently utilize the available lowest signal in such places. So you have these smart antennas that are able to scan, and they can pick from any network. It could be MTN, it could be Airtel, because most of the challenge we have is that in most of these rural communities is that you find in some area, they say MTN does better here. And then some area they say Airtel does better here. So you can't always plan for all these eventualities. So these systems will scan what's available in the area and utilize that to communicate. And then within itself to broadcast a Wi-Fi for the end users with the tablets to connect and work. So you don't need to buy routers, you don't need to buy other external systems to support your network. Power, the system uses green energy by solar. And so in terms of the hardware, the system comes with a solar panel. That also has the plug and play components that just fit into the system. And this power and this solar system can support up to 3 days without power. So which I think is a good way to start with. If you're going to have power half of the week, and then you have a solar system that can support you for 3 days without power, then it guarantees the system uptime and availability. So when you talk about the successful digital systems, we say 100% system uptime because we have 3 days of running on solar without power from your main source. It could be Umeme in that case. So you have the solar that comes in to fit into that gap. Then also the system reaches 100% of the users. The system is designed to meet, I think, because any system needs to have a category of users. Currently, the system has users in terms of stock managers at the health facility. Then also it has users in terms of the district health officers, because these also have to view stock status and be able also to authorize these stock transfers and stock refills. The system is also able to do real-time data visibility and also able to be interoperability, being able to integrate with any other existing system. I think this was mentioned it already. and also able to leverage existing solutions because the system can integrate. It has allowance to build or add on functionality from other systems like the central warehouse. We talked about the pharmaceutical information portal, and those other systems can work with. So just to walk you through the general architecture of the system, I'm just going to walk through the infographic that you're looking at. On my left, which I think is your right, we have what we call the health facilities. That's the starting point of the system in terms of its implementation. So at the health facility, you see we have a tablet with a Wi-Fi signal. That's the terminal that the health workers interface with. One, to, as you can see, to manage commodities, but also to create requisitions. And then these transactions are posted into the micro server, which is connected within a distributed network of the S+ systems. You can see we have S+ and DLT. DLT in the video was mentioned as a distributed ledger technology, which allows this database to be distributed across this network. It's more of a private network. You can look at it as a VPN that all, for example, you can look at a district, maybe Chiriandongo, all health facilities are linked in this private network. So any facility at a time can run queries and see stock status in any other facilities. So they're able to tell if maybe which facility has more stock levels where maybe on a product where they're running low, and then they can maybe plan or schedule a restock from that facility. And then we can also we have the district health officers. They're also able to access the system. We have a terminal that will be installed at the district level, and they can also interact with the system. They can query the system and also manage requisitions. Also, they can view stock status and also access across the district and authorize any stock redistribution within the facilities. Then if there's a need to communicate at the central warehouse, we'll identify one of the micro server. If you can say there's a node we call internet connected node. So this is the node that will act as a gateway to allow communication to the national warehouse. For example, this could be a system at the ministry. For example, we have DHIS2, NMS ERP, and it could be exchanging different important information. This could be information on stock status or patient information. All these are details that can be determined depending on the nature and the circumstance for what data is required to be integrated and communicated across the systems. If you can allow, maybe we look at the success.
All right. Yeah, no, I think we can actually go ahead and look at the successes. I think as you are breaking those down, maybe we can get some insights on data around the number of people that have been trained so far that are actually on the platform within Chiriandongo district, even as we break down the successes. Yeah.
So you can see that from the slide, we are showing that remote stock management, we can show that 46 health workers have been trained, 18 were women and 10 were youth. In terms of the demographics of the number of people that were trained, just to respond to that question. So we also like to speak on the lessons learned during the implementation of the S+ system in Chiriandongo. One of the key lessons that's very critical for us is that for any tool or system that's going to be doing inventory management at these lower tier facilities, it has to be able to communicate and integrate with other systems. You cannot have a successful system that is going to stand alone. Otherwise, it will create, either it will duplicate what's already existing. So it's very important for any system to be able to integrate with these existing systems. So either that allows to add functionality, but also being able to exchange information that may be required by different stakeholders, could be the ministry and other partners, either locally or even internationally. So the system has to be able to communicate with other systems. The second key lesson that's very important is that the system has to be designed with the end user in mind. So the system has to be human being or user-centric. So because if you have a system that has been designed without the input of the end user, then you'll have challenges of adoption and utilization of the system, because users, one, may find that the system does not align with their process of work. So all these are the details you agree and align during the design and implementation of the system. You have to get the users involved. Then thirdly, it's very important to have strategic partnership, because these systems, you see, they touch different stakeholders. You have the health facilities, you have the district health officers, you have different partners at local, international level. So you need to get all these people involved, have their input, and also they give you the advice on where probably the system could be of value to what they already have. So it's very important to have engagement and also build these strategic partnerships at the different levels. Then number 4, also we need to conduct what we call continuous end user support and training, because what happens is that we have one of the issues, staff attrition, that at these facilities, staff numbers keep changing. You might find the people that were trained, you go there next month or next year, they have moved. So how do you ensure this continuity? You have to follow up and ensure you do this continuous training. And then number 5 is building communities of practice through continuous capacity building. Unlike the conventional trainings where we used to convene meetings in a hall and then call people from different districts, it's a bit costly because you have to put in logistics costs. But we want to ensure that we use the electronic platforms to provide the material, and people are able to have these refresher trainings, and then you're able to support them remotely to ensure you build this capacity and training without people necessarily moving, because one, they have to leave their work, and then that becomes a challenge, and then so there are costs related to that. So we want to ensure that within the platform, the training materials, the modules are embedded within. So once you have new people, new staff, they just have to be embodied, and then remotely, you can take them through the training and the refreshers so that you build capacity and ensure quality usage of the system, and also that the system is utilized as intended. I think I'll end it there.
All right, thank you. Thank you very much. I like that. Yeah, we have been given the next direction. So Peace, perhaps you would like to talk a little bit about sustainability. As UNCDF, that's really an important part of the projects that we do. It's important that they get a life of their own and are able to scale outside of the support that UNCDF provides. So maybe you can give a little bit more context to how the S+ platform is doing in that regard. Thanks.
Thank you so much, Esther. That's a great question. Maybe before I go into the aspects of sustainability, allow me to just circle back to some of the successes that we've been able to realize. In alignment to the National Bubu Policy, through the implementation of this, we have been able to set up an assembly plant for the solutions that my colleague Dennis talked about. So at a facility, it's a 4-piece hardware that is deployed. You have the tablet that is commonly referred to as the terminal that the health worker or the district official will interface with. You have the micro server that is primarily the heart of where the transactions are stored. You have the solar panel that works to facilitate power distribution to both the terminal as well as the server. And finally, you have the smart antennas that are able to pick connectivity from either the nearest cell tower or the most available network in that context. So you asked about sustainability, Esther. We look at sustainability as a threefold process. We look at it at project level, at stakeholder level, and at technology level. So in regarding the project level, we have been able to register an accepted proof of concept by the Ministry of Health. We are leveraging this to continue to integrate vertically with other systems. One of the things I need to mention is that the stock management app that you saw in the video is just one use case. The S+ platform is available and ready to host a number of applications that I'll be able to show you. Currently, we are working on an integration with the NMS ordering app. So it's the same infrastructure, just a different application. So the idea is we would like to set up, particularly at lower tier, an infrastructure that would be the single last piece of hardware there. So different stakeholders can come in and be able to host their own applications, running their own systems and harnessing from the advantages that the infrastructure and the technology provides. At stakeholder level, we have been able to build key relationships with health system stakeholders, including but not limited to the Ministry of Health, naturally providing oversight and guidance as to the direction this should take. We've also been able to engage with the district leadership, particularly in Kiriandongo, to ensure that they are understanding and realizing of the benefits that data visibility provided by the solution has in terms of easing their work. To the implementing partners. In this particular case, we worked with Baylor to be able to smooth some of their support operations. One of the things that the system does, which is a feature that we particularly like, is the availability of remote updates. So you do not have to go to a particular site to update the software to a newest release, or you do not have to go to a site to fix certain bugs. This can be done remotely, and that impacts greatly on the costs of running a system when it comes to understanding logistics, transports, hiring a vendor to actually get onto the site to do this. So this was one of the areas that we thought would be important to ensure more sustainability of this. As mentioned, the system is currently being integrated with the NMS app, in addition to the likes like DHIS2 that is already ready. Of course, we are governed by standards, particularly the HL7, which is the health level standard for integration of health data. At a technology standpoint, the system, as I mentioned, can do a lot of things. One of the use cases that we piloted in Kiriandongo was the stock app, but that's not the end. The future of this platform is to be able to integrate things like drone deliveries, insurance, patient services, medical devices, community health platforms, as well as pharmacies and circles. So the idea is for us to have set up a technological stack or platform that other stakeholders can come together and build up on, to ensure that facilities that have no connectivity or that are digitally challenged in terms of infrastructure are still able to use these systems, and therefore realize the benefits up the value chain, especially for the decision makers at district and at ministry level. So thank you so much, Esther. I will stop it here.
All right, thank you very much, Peace. Development partners, private sector partners in the audience, I think the call to action is quite clear. Yeah, so thank you, a big thank you to both of the panelists. I think a really big takeaway for me from the discussion has been the importance of user-centered design, especially when you're coming up with these programs and platforms, making sure that you're pivoting where you need to cater for the audience on the ground, especially when dealing with a lot of these last mile solutions. So we are closing in good time. I'm going to open the floor to questions. I don't know whether there's someone that has a question. Yeah, please feel free to put up your hand. Rachel will bring the mic to you. Well, are people very clear? Okay.
Thank you very much, Peace and a colleague, for that elaborate presentation. I only have one area of concern. Will it be possible for any health providing organization, being it a pharmacy, clinic, drug shop, to come to your office and they talk over the business, and they can be connected with this service? Apart from that, I knew of medical access as an organization that is able to supply, give medical drug supplies to the health settings. Do you still maintain that? I have been warmed up actually to surface with you. I'm glad God has given me this opportunity. Thank you very much.
You
want to take both questions?
Yeah, okay.
Thank you. Thank you for the presentation. I think the system looks like a good one. My question is just about, you mentioned how you're using sounds like conforming sounds like HL7 in the development of the application and the system. I want to be sure, how exactly are you conforming to HL7 in this application?
Thank you. My name is Otim Dan. I'm a medical student. My question, well, this solution that you have come up with is digitalizing stocker management. problems. And my question is that how are you also solving the problem of drug expiry at the different health facilities? Because we get problems whereby I hear of drugs getting expired and then health facilities, and yet it could be needed at different other health facilities. So is there a way that this solution that you've come up with could be able to maybe take note of that and move it to the next health facility where it is needed, where they maybe have stockouts of the such drugs that may be able to expire within the next few months? Thank you.
Okay, I'll take on starting with the last one first. You asked a very great question. And if we didn't highlight it enough, I'll just circle back to some of the features of the system. So rightly put, when we came up with this concept, we were trying to address some key features. First and foremost, lack of visibility of stock level data, which would lead to things naturally like expiry of commodities, issues with traceability of the drugs. So the system in itself has a couple of checks that ensure this. First and foremost, to prevent expiry, the system has enabled fast expiry, fast out. So the commodities within the stock manager view will be arranged in order of which commodity expires first to ensure that the health worker is able to issue out that as opposed to issuing out something that expires 2 or 3 years later. For the visibility layer at the district level, the district team has visibility over stock levels for all facilities within their district. So they're able to see facility A has potential to expire over commodity X and therefore can redistribute that facility to other health facilities which are low to ensure that those drugs do not expire but are consumed within the time that is allocated. You asked about standards. Now, I'll answer that question beginning with, we are all aware that a system is only as good as the data that it's able to produce. So innovating the technology is one aspect. The next one is to be able to use that data for decision support at the different levels. While designing the system, we looked at primarily ensuring that we were providing interoperability across the board to the different actors at the different layers and with the other systems that support the ecosystem. Now, to carry out interoperability, you need to be aligned with the laws that are set up internationally and locally to ensure data exchange, master data management. And I think one of the presenters in the BRAC section actually talked about this, and he mentioned it quite well, Brian did. He said that it's not enough to integrate system to system. You need to be able to have your system ready to integrate with also international systems as well as local systems. So we looked at standards like SDMX, which is a statistical data meta exchange, which governs how master data is utilized, HL7 in relation to also master data management. And because we are in the futuristic slide you saw looking to integrate with EMRs in the future, it was important to make sure that we are aligned to standards that will allow us to share details of patient level information, clinical aspects of drugs and the like. So what we did was, as opposed to wait until the end when we have to do these particular kinds of integration, was to make and design the system scalable and ready such that whenever we are called on to integrate with any other system, we have the capacity and means to do so. The last or the first question was around whether or not a clinical operation can come up or a pharmacy to utilize the technology. The doors are always open. One of the things that I would like to communicate with this presentation is that we would like to grow this beyond just a stock management app. What we are trying to do is enforce digital transformation. And that means that we are providing a platform to allow organizations with their own technology that are struggling with infrastructure challenges within these rural settings to come and integrate, come and meet us and have us be able to use our platform to ensure that users can access your data and excluding the infrastructure challenges that they would typically face. You asked whether Medical Access is still in the business of distributing medicines. Yes, we are. Medical Access, as I mentioned in the start, is a private warehouse. We do other things, but supply chain is still at the heart of that. And it's something we continue to do, though, as you know, you keep evolving to add on more aspects depending on the need. So we are still available and we are open to discuss wherever the need arises. Thank you so much. Back to you, Esther.
Thank you. Thank you
Esther,
very
can you take
much.
one more question?
I think yes, we do have time for one more. Yeah.
Thank you so much for the presentation. My question is about within the system. Okay, for most enterprise resource solutions or software systems regarding supply chain, normally there is, because the interaction with the system is human-based, it means it's based on the data put by the human being. So it does not give visibility on pilferage. So it means that the inventory within the system is based on what the staff put in. So is there a way you found around that problem? The accuracy of the data?
Okay, so that's a great question. And again, it goes back to initially some of the principles that designed or led to the design of the system. Traceability, you've talked about pilferage and as well expiries. So with the aspects of pilferage, this is something that we tackle in a two-step approach. As you rightly put, you know, the system is reliant on what is inputted initially by a human being. So we work together with the health facility in charges to ensure that at the start or at install, we capture all records available for the stock, but there are also DQAs done from the system together with the IPs as well as at the district level to ensure that the data that is there is actually truly reflectant on what is actually in the stores at this facility. So we don't exactly exclude all human interaction because, you know, with systems, you still need the user aspect. But what we do is ensure that we have built the right capacity first at health sector level with the health facility in charges, working together with the implementing partners, as well as the district teams to ensure that we are capturing any anomalies that might be identified. Thank you.
All right, Dennis, I don't know whether you have anything you'd like to add to any of the questions. Yes.
Yes, maybe just to add on on her question regarding how do you ensure data safety, is that the system by design is designed to ensure that it complies to some of the standards, to ensure either there's full proof for that. So there's what we call the CIA, which looks at confidentiality, integrity, and availability of the data in the system. So the system is designed that access to data is by a user that has been defined, authorized, and given access, and all transactional records are traced through the system because it's a bit transparent and you have visibility across your database. So in a way, I think you have records that can show this and that is protected within the system. But again, we say that all systems, the risk is there. So it depends on how motivated, how persistent the evil actor is, but the system has protection for that. And any transaction, or given that, because we indicate that the system uses what we call a DLT, the distributed ledger technology. So any transaction and any access is approved by a key. So we can track and see how the data is being utilized. So in a way, the system provides that transparency and also controls to safeguard against data theft.
All right, excellent. I'm actually into you guys' lunchtime now. So thank you so much, Peace. Thank you so much, Dennis. If you guys would like to interact with them a little bit afterwards, you can meet them in the lobby where we're going for lunch. Thank you very much.
Thank you, Esther, and thank you for this wonderful session. Right about now, we're going to go for our lunch, but when you look at your program, kindly ignore a certain error that was made. So our next session, the breakout sessions will be from 2 to 3. Yeah, I think there was a printing error. I needed to correct that. So lunch will be served in the respective rooms we had yesterday. Nile will be having, the speakers and the delegates, and then Choga will have the speakers and the VIPs, and then Choga will have the delegates. So after lunch, we shall have very interesting sessions. Having discussed all these things in the last 1.5 days, how are we working towards achieving universal health care, universal health coverage? And you realize that that is an interplay of many sector players. So in that, we shall be discussing how the private and the public sector is working together to achieve this. You will see the role of the banks, insurance companies, how they're working together to make sure that they can facilitate the national insurance plan that is actually working. And then what are the social innovations that can drive some of universal health coverage? And we shall have a lineup of very interesting speakers. So that will be in Addis, please take note. And then in this hall, we shall have a very interesting session 2, and that is to do with global health security. And that will be led by Judith Nanyondo from GHS at IDI. And in ACHA, we shall also be having another interesting session that is evaluating emerging technologies. So you've heard about drones, you've heard about blockchain, medical access is using distributed ledgers, so how do we evaluate some of these technologies? So there will be a session on what has been done to evaluate drones in Kalangala and West Nile. Most of us interacted with chatbots during COVID, to diagnose ourselves or to recommend, medication. And those are driven by artificial intelligence. So what evaluation do we have for some of these technologies? And so to that, we shall have a team from IDI, the Center of Excellence for Bioinformatics, that came up with a chatbot for COVID and Ebola. So they will take you through their evaluation of that application, the chatbot. Then one of the colleagues from the academy has been working on a predictive model for NCDs in HIV care. That will be Caesar. He will tell you more about it. Then we have a gentleman joining in from, I think, Malaysia, who is also using artificial intelligence for healthcare. So that will be it. These are very interesting and engaging sessions. And from the feedback we got yesterday, I think you appreciated the lineup, the conversations. So just to remind you, in Katonga here, we shall have global health security and climate change. Then in Addis, accelerating universal health coverage. And then in ACHA, we shall have emerging technologies, their evaluation. Interestingly, after lunch, we shall be honored to host the Permanent Secretary for the Ministry of ICT, Dr. Amina Zawede. And I know most of us haven't had time to interact with the exhibitors here. So as it was with the US ambassador yesterday, all of us after our lunch, we shall convene in the gallery and we shall inform you about the setup, but the people who have been exhibiting will have time to, explain more about what they're doing for about an hour. And then we shall come back to Katonga here for the closing ceremony by the Permanent Secretary from the Ministry of ICT. So thank you so much and have a wonderful lunch. back from lunch. I hope it was great. For this breakout session, we have a very interesting Hano from Global Health Security at IDI. We all know the crisis that we have faced for the last 2 years with COVID, now Ebola, but given our history as a country, we have so many outbreaks. And there's a global conversation regarding climate change. So now there's also a crisis with climate change. And all these things directly speak to healthcare, you know? So with us today is a panel from Global Health Security. It will be led by Nanyondo Judith. She will take us through what the panel is about, its relevance, and then she will call up her panelists, and then she will, take us through the rest of the presentation. So over to you, Judith. Thank you.
Thank you, Martin. We welcome the opportunity that we've been given as the Global Health Security Department to discuss together with you and share with you this very interesting topic today on climate change and global health security. So as we start our session, as a background to this session, we all know that climate change poses critical challenges to human health and biodiversity. The World Health Organization states that climate change is really a significant and emerging threat in public health and changes the way we must look at all the aspects of health promotion to be able to protect the vulnerable population. Recently, urbanization, globalization, increased human population and mobility, coupled with environmental changes, have significantly facilitated so many factors that are promoting issues around climate change, like migration of disease vectors, and all this is really having a great impact on our environment. For today, this session we will be discussing advances that have been made in tackling the threats from rapid response teams, coordination, community surveillance systems, and structures that have been put in place, training and health information, and different aspects that have been put together to see that issues around climate change and public health can be well addressed. I'll be the moderator for this session. My name is Judith Nanyondo, and I work with the Infectious Diseases Institute. And at the Infectious Diseases Institute, I lead the Global Health Security Project that is funded by CDC. On our panel today, we have distinguished panelists, and allow me to introduce them to you. We have Shaban Senyange, who is representing the director of the National Institute of Public Health, Dr. Alex Ario. He wasn't able to make it, but he has sent us a very great representative, and I would like to welcome Shaban Senyange to the floor. Shaban is an epidemiologist with the National Institute of Public Health. And interesting to note is that he is an award-winning wildlife health and conservative media specialist. Shaban, you're very welcome. Our other panelist is Dr. Ekwaro Obuku. Dr. Ekwaro Obuku is a senior technical advisor working with the Ministry of Health, seconded by the Infectious Diseases Institute. He's a senior technical advisor for data and policy, working with the National Action Plan for Health Security team. Dr. Ekwaro Obuku, you're welcome. As he takes his seat, this topic today is extremely exciting, but quite often many of us do not relate with this topic. We feel this topic is far away. We feel when we see the fires in the US, that is far from us. When we have these zoonotic diseases, we do not have a role to play as individuals or as a community. But before we start this session, I would like to ask us in the audience, can you paint a picture of climate change in your community? As an individual, what is your perception of climate change? Can we get someone from the audience to just give us your view about, in your view, in Uganda here, what do you think what is climate change? I would like anyone to give us his opinion before we start. Thank you.
Thank you. Good afternoon to you all. My name is Namaganda Hope, and I spent most of my time during my studies in Northern Uganda, Lara. So my perception of climate change, from my experience living in Lara City, is the change in patterns of the temperature and rainfall cycle. Being in a community where most people depend on the agricultural products, the climate change that is happening has really affected their productivity in this sector. And so, to me, that's how I take climate change.
Wonderful. Maybe just before they take the microphone away from you, how do you relate that to global health security? How do you relate that to public health emergencies?
Okay, thank you so much. As a public health graduate, I cannot help but define health as, in the broader sense, it's a holistic manner. So when we talk of health, we not only see disease, but very many other aspects, and anything can affect health. If we're talking about climate, for example, my people in Northern Uganda were expecting to be growing more crops within those last months of before November, October, September. However, the rain did not come and it was insufficient, so they weren't able to produce. And then with the recent cases of hunger we had in Karamoja, now we are also in fear that within the next few months, we'll be experiencing the same thing in Lera. And if action is not taken, we will have more children suffering from the nodding disease, malnutrition, and so many more. So I think climate change is a very great aspect to health. Thank you.
Thank you so much. I think she has nicely painted the picture. She has nicely painted the picture, and I would like to invite Shaban Senyange to further open our minds to what the impact of global warming on our health of vulnerable populations can be. Shaban, you're welcome to the floor.
Thank you so much, Judy. I think the discussion just earlier has helped, set the pace for what I'm going to talk about. My name is Shaban, epidemiologist with the National Institute of Public Health, and I'm here on behalf of Dr. Ario, our director. To answer what Judith has asked earlier, for me, when I think about climate change, a quote comes to mind, and it's from one of my favorites, called Jim Fowler, who said, "The continued existence of wildlife and wilderness is of great concern to the quality of life of humans." And often when you talk about our health is intrinsically linked to the health of our environment. So whatever happens to the environment obviously affects our own health as well. And it's important to start this discussion thinking about that. Back to the discussion, if I'm to think about just one line that sets the pace for this discussion, is that quote right there that says, "Nature will always strike back." And earlier when we were chatting, I was thinking about us starting this discussion and looking at impacts of climate change on health of vulnerable populations. But it's also important as we go on with this discussion to actually think about these impacts, or what is happening in the environment is as a result of what we are doing as a human population. Whether you're thinking about deforestation, whether you're thinking about driving species to extinction, whether you're thinking about unsustainable environment patterns. These are things that we're doing as humans that are causing these effects in the environment that are in turn affecting our own health. So as we are talking about the impact of climate change on health of the human population, it's also important to reflect on what the human population is doing that is actually driving the conversation in that direction. and thinking about extreme weather conditions, say in form of, global warming and the consequences that are resulting from that, say food insecurity, like someone highlighted, whether talking about floods, whether you're talking about the, reemergence of some of the infectious diseases that we are seeing, it's important to start to think about that and connect the dots. Then again, someone mentioned about, global warming being the rise in temperature. And right now, the discussion in the world is looking at how we can prevent the global temperatures from further rising. And this is why I was talking about earlier, what are we doing as a human race to be able to curb those temperatures from going higher than they already are? And this sort of captures, the main theme of today's discussion, looking at the overview of climate sensitive health risks, their exposure pathways, and the vulnerable factors. And if you're looking at vulnerability, there's aspects around, social, economic factors. You have demographic factors in terms of location. You're looking at issues to do with, ability of these health, the populations to be able to support livelihoods and things like that. When you're looking at exposure pathways, you're thinking about the extreme weather patterns that are causing disruption in, say, food systems that are increasing the zoonotic interfaces. And most importantly, this discussion, I hope, takes the form of looking at the health system capacity and surveillance system, which is one of the gaps that really needs to be tapped into to create a change in where we are taking a direction, looking at the interface between climate change and health populations. But if you're thinking about climate sensitive health risks, there's a lot of issues that you might want to tap into from, the screens went down, but that's okay. Okay, we're back. Yeah, so if we're looking at some of the health risks that we're looking at, I earlier mentioned issues to do with water-borne diseases that we're looking at in terms of, say, key example is cholera. I was conducting an investigation of a cholera outbreak in a refugee settlement, Nachi Valley refugee settlement. If you're looking at issues to do with vector-borne diseases, right now, the country is going through an upsurge of malaria. And if you to tap into that, you're seeing a lot of changes in seasonality and breeding cycles and distribution of, these other patterns. If you're looking at zoonotic diseases, I mentioned earlier, the issue that we're facing about some of these diseases that haven't been as rampant, case in point, anthrax. Some districts are now reporting anthrax outbreak every year. I was in Kwen just 2 months ago looking at another outbreak investigation on anthrax that was happening in Kwen district. So we are able to see most of these things happening, but because of the changes in some of the patterns that we're seeing, this is really just an in-depth discussion to something that I highlighted in the previous slide. If you're looking at the vulnerability factors that are sort of looking at populations being disproportionately affected, the socioeconomics, looking at income, looking at education levels, the demographics, the extremes in age being affected by climate change as well, the demographic, geographic factor, someone talked about, this affecting accessibility to healthcare, and biological factors in terms of comorbidities, in terms of HIV, and all those underlying disease conditions can obviously be impacted greatly by climate change. Obviously, we're also looking at indirect and direct health impacts of climate change, whether you're looking at heat waves and the waterborne disease that I talked about, stress, mental issues as well, food poisoning, and this I believe we'll be tapping into when we get into a more detailed discussion. But what I wanted to draw your attention to, though, going back, is the increase in respiratory diseases. Obviously, if you're talking about climate change, then the concept of global health and global emissions comes into question. And just to remind everyone, Kampala is arguably the second most polluted city in Africa. And what that means is you have all these greenhouse gas emissions that are in circulation, and obviously taking that in has a huge impact that is playing on the health of the population. Obviously, skin cancers and cataracts as well, the cases are they're increasing, and you can see the statistics. By the time we get to 2050, this is going to be even more within the population. But what I wanted to draw your attention to is obviously the concept of the intersection between humans, animals, and the environment in general, a concept that is known as the One Health. And we are one of the youngest populations in the world. And with that population, obviously the pressure on resources to support the population is going to become bigger. What happens now, you're having more humans getting closer to protected areas to support livelihoods. And what that is doing is creating more interaction between humans and animals. And what happens if you're cutting down forests where these animals were surviving, the animals have died, and these are areas that are rich in different kinds of pathogens. What the pathogens need now would be a new host, and we present that opportunity. COVID, classic example. I think what COVID did, if you're looking at bright spots in the middle of a catastrophic event, what COVID did was really shed the light on how the human-animal environment interface is so important, and how disrupting that relationship can actually cause a catastrophic event of that magnitude. And part of the discussion should really be, drawn in that direction. And if you're looking at the statistics, the World Health Organization estimates that about 3 million people die every year from diseases that are coming from animal origin. And 75% of the 30 new pathogens in humans have been traced back to animal origin. And this just goes to show how important it is to keep this relationship as healthy as possible. Because if we disrupt that relationship, then we are going to be registering more viruses. I came across an article that was written by scientists that were predicting that we are on the verge of another potential pandemic if we do not change how we interact with animals. And this just goes to show how important and delicate that interaction is. And that for the innovators out there that are thinking about tapping into this space, I would say this is one of the most underrated sectors, looking at that interface. But if it is merged with health innovations, digital innovations, and supporting livelihoods as well, then it has the potential to actually create a wave of looking at health from a holistic approach and taking into aspects impacts of climate change. Then again, it is important to think about the people that we are trying to create these solutions for, take into their own, account for their own needs, community level, and taking that on board to be able to create the interventions that we need. And I believe Doctor is going to really go into a much deeper discussion about what is being done at that front and what we can learn from those interventions. Thank you.
Thank you so much, Shaban. That was a really wonderful presentation, and I'm sure that we have taken notes. And the key point here is we are a young population. We are a growing population. The interface between the environment, the human, and the animals is stretching the resources that we have. Few years down the road, what is going to happen to the people that we will have around, remaining around, in terms of ensuring that the impact of climate change they are not affected by the impact of climate change. What can we do as individuals to avert that impact? So that is one of the things that I want you to think about. It's one of the questions I'll pose to our panelists later, but your participation in that will be very important. What role can we play as individuals to be able to avert the impacts of climate change on health security? Our next speaker, Dr. Ekwaro Oboko, will take us through what are some of the models, the innovations, what is it that we have started doing as a country to be able to build resilient health systems, to avert the impact of climate change on health security? Dr. Oboko, you're welcome.
I'm going to stand. I prefer to stand. Is it working?
That's okay.
Thank you very much. I'm old school. Hmm? Of course, is when you stand, the pictures come out better. And you know, I've just got a job. I need to show results, take good pictures. Hmm? So first of all, let me thank Judith for inviting me here on short notice. Short notice is my middle name. Is what I learned when I was the president of Medical Association. No budget, no work plan. You have to deliver a salary for people who don't even want to work now. And of course, Senyange, thank you for setting a very good foundation. I'm happy to see my teacher, Honorable Minister of Health, former. I was just telling a young man there how we started the pediatric clinic 20 years ago. Then I realized I'm actually old. Hmm? And of course, Dr. Sekabri, your colleague, and most of all, I discovered the deputy director of this program is my classmate. So I knew I had free lunch today. So in terms of health security, what is health security? You know, we discovered that security using guns and nuclear warfare and sending everything to the moon was not the ultimate, isn't it? The Americans discovered that all their machinery was not that important after all. They were dying more than us, isn't it? They had to change General Motors to start manufacturing ventilators. They just didn't have enough. And they still died. So what is health security? Probably we are looking at prevention, isn't it? Health security is actually preventing these things from happening, as opposed to, next slide, as opposed to, you know, waiting for it to happen. So lots of effort in prevention, because even countries, next slide, please. Oh, it's me. Oh, you know, I'm used to being a boss when I was president. Shift for you the slide. Now I'm on my own. Okay. So health security is that, you know, ability to prevent, detect, and mount an effective response to things that threaten our lives. And there's a full plan, by the way. Ministry of Health has very good plans. They are there, okay? Called the National Action Plan for Health Security. And there's a lot of activity going on that is not known to us, especially, of course, when it's not broadcast. And that's the team there. We call it the acceleration team, supported by Resolve. You know, you have to recognize the support as part of the. So that is the curve he was talking about. If you can't read the details, the green is the reporting rate, annual reporting rate, and the rest are the new or re-emerging, you know, viral hemorrhagic fevers. Okay, and human African trypanosomiasis is there, and the blue is anthrax. So the general story is that these things are increasing, and they are not going to reduce. This is the second thing. The other thing is that Uganda is the kitchen. Is the kitchen for these things. We have the highest outbreaks of Ebola in the world. Okay. There were 8. Ebola and Marburg, there were 8 in a space of 15 years, and plus these recent outbreaks, I think about 10, 12. In fact, there have been so many. And we're also beginning to see heavy rains recently in Mbale. You saw that, yeah? And this is something which happens year in, year out, year in, year out. People continue to settle there. So what are the innovations are we going to do? Yeah, this is the question I think which comes about in this conference. So there is this thinking about early detection, early response, and continuous quality improvement. And that is the conceptual framework. It's not very clear there. Maybe I won't waste time, but you know all that. And this has come out so badly. But I'll say something about the 717 framework, that there is a thinking that we should be able to detect these problems within 7 days of them happening. Now, if you put the 717 framework around Ebola, it took us over 30 days. I hear it is 45. I hear. I'm also talking carefully because I still need to pay school fees. January is a bit, but we took a long time to detect. And you know, we have all these big partners flying in Prados, WHO, surveillance department, US government, what? We also have a surveillance. So what is it that we are not doing properly? Notification within 1 day, that has to do with Of course, the detection sometimes takes long, like yellow fever, because you have to confirm in the lab. I hear the experiments take long, but within 7 days, we should be able to know. Then notification to report to the next level of authority within 1 day, and then mounting an effective response. Those of you who sat in the National Task Force, you could hear. And those of you in Muvende, if you had the radios, you could hear, you know, one partner is coming from conducting an activity, another one is going to conduct the same activity. And the people there were saying, we are seeing a lot of dust and parados, we are not seeing anything happen. You know, so mounting an effective response, very, very important. So sometimes the solutions are with us, but how do we make them efficient? So innovation can be around efficiency, okay? So I'm just going to give an example. I came across so many tools. That's the other thing. Everybody has a tool. There's a tool called the STAR, another one called VRAM, another one called the Enhanced Situation, ESA. I also discovered a lot of abbreviation in this world of development. And every development partner does not build on the other one, says we are innovating. When you look carefully, it's the same thing. The song is in a different way. So there's this other one called Enhanced Situation Awareness. And that is the team, the A team, the so-called acceleration team with some stakeholders in Mukono early this year. Really looking at how do we use data to inform our preparedness and response activities for what we know is likely to happen, which has been happening even before the white man came to Africa. They knew the rain season, they knew when famine is coming, they knew when they needed to burn the grass, isn't it? So that we have new shoots for the grazing lands, you know? But how do we now use data to predict and so on? And one of them is this ESA, where you have seasonal calendars. And I will show you the seasonal calendar, which actually we prepared early this year, I think. And it showed that the floods were going to come in Mbale. But once the floods came, I asked my colleagues, but did anybody use that report? Which we came about to make stakeholders, Office of the Prime Minister, Meteorological Center, Meteorological Authority, tell us about rainfall and so on. All those people were there in that meeting. So the question is, how do we use this data, seasonal calendars, to prioritize risk? Then contextual factors, which he has talked about, like population density and disease endemicity. These ones pre-exist. And then there are things that change, dynamic risk factors, like natural disasters or political unrest. And then do we have thresholds which we trigger us to take action? So these feed into that enhanced situation awareness, and I will show you shortly how it looks like. So, so how do we innovate? Do we need new tools all the time? My thinking is, actually my thinking is that we have enough. My thinking is that we just have enough tools around. So we have all the tools, we just need to repurpose them. And a simple one are those risk matrices. We know, we estimate the risk, its likelihood of happening, its impact, we characterize it and attack it. The other tool we need to use probably more is what we talked about, a One Health approach. You know, I'm fortunate that my team has a lawyer. And one time we were at the NTF and she said, you know, you people, the president has said we lock down Muvende, but it has no legal backing. You know what I mean? So she was very instrumental in formulating the COVID-19 rules and also guiding that we need the Ebola lockdown rules so that, you know, these things can be enforced by authorities. Otherwise, the presidential speech is not a policy. We have a veterinary surgeon in the team, epidemiologists, and so on, which strengthen the team. So a One Health approach is inevitable. And I think one of the innovations is to change the curriculum in schools. You get what I mean? A One Health approach is very, very important. The other innovation is, if we scored so badly, and I must speak about IPC, because IPC pays my salary. So linking it to this climate change and increase the risk of Ebola. When Ebola breaks out, apart from the community people who died, 22 probable deaths before we discovered it's Ebola, health workers die. Okay, so if health workers are dying, Why are we still having people called health inspectors and not IPC officers? Are we changing with the times? So how can public service innovate to substantively put someone there who looks at IPC issues? Now that we know Uganda is at highest risk in East Africa and probably globally. So this is, in fact, as he talked, I started formulating my plan, whom I'm going to see in Ministry of Health after this. Because you get that moment of eureka. Oh, I've seen it clearly. And thanks for Judith inviting me. The other innovation would be, I think I've talked about it. So this is the calendar. I think you are thinking it's going to be like an app for iOS, where you enter something and it comes out. It's Excel based. You put back my Excel, Chief. Put back the Excel. I show them how Excel is very powerful. So that is the Excel, and it's very simple. You select multi-sectoral teams on 6 specific hazards, which we thought were priorities. The first one is landslides. Second one is floods. The third one is influenza and influenza-like illnesses. Viral hemorrhagic fevers. We focused on yellow fever. At that time, we didn't see Ebola happening, because there are all these publications showing Uganda is leading from Ebola to everything. Then anthrax and cholera. Okay. And we sat down in these teams and we started mapping using the risk matrix. We prioritized preparedness activities 3 months before them. For instance, 3 months before you. So you come up with a calendar and say, according to our risk, the risk of landslides in January is very low. Okay. Sorry, is moderate. And then in Feb, it is low. But around April, May, it is very high. And then October, November. What does that relate to? That period, if you are following. To grasshoppers, but what brings grasshoppers? The rainfall, right? So it is anticipated that, for example, in January, you should start activities, preparedness activities for April, May. That is the idea. And that is point number 3. So in October, November, by July, for the October, November rainfall, by July, you should start preparing district, local governments, and so on. And when we mapped this, it was around March. So we hoped that by July, the district rapid response teams, including partners, would have started the preparedness activities. Where will we locate the people? Isn't it? If floods happen, and so on. Are there will the schools be closed at that time? Those kinds of the innovations, really enforcing what is already known, is key. I think this for me is the most important slide, even if I stop here. But and it seems I've stopped there. Now, this is a project. This specific project of 717 is funded by Resolve to Save Lives, and the contacts. The correct person to have come is called Lydia Nachire, but she's in Rwanda now attending a conference there. And her email is lnakire@idi.co.ug. That is the person you should contact for more details. She's really a guru in this business. But when it comes to policy issue and politics, I can also come in. Okay, thank you so much for listening to me.
Thank you so much, Dr. Oboko, for that wonderful presentation of what we have. As a country, we have done something. But from the presentation, I think you and me who are down there are asking ourselves, we have these tools. What is it that we can do? What are the gaps that still remain in terms of being more innovative to be able to avert some of these public health emergencies that are impacted by climate change? So I will ask Shaban to shed some light on. He has talked about these tools. He has talked about some of the innovations that are out there. But what are the gaps that still remain? What is it that we can do as individuals? But I'm sure Shaban would also want to throw it back to you. What is it that we can do? We have this information. By we mean you who is out there, the community back home, and other stakeholders, the politicians and others. What is it that we can do to be more innovative, to avert these public health events? That's for Shaban. And later, I will also ask Dr. Oboko to again think through and hear from him. To reemphasize, one of the points was we have a growing population, and we are stressing the resources that we have. With this growing population, the different stakeholders, what role can we play to be able to avert the impact of climate change? By stakeholders, again, Dr. Oboko, we have different stakeholders. As an individual, I'm a stakeholder in this community, the community out there, the politicians, the different levels of people that make up this ecosystem have a role to play. What is it that they can do as individuals to avert the impact of climate change on our health security? I think I'll start with Shaban to share his thoughts, but feel free to throw it back to the public there to also share their thoughts too. Thank you.
I think that's going to be the option that I take, throwing it back to the people. But I think Dr. did touch a bit on, something that I can expound on. And I will just use a classic example of a conversation that me and him have shared about, zoonotic diseases that is shareable from animals to humans. If you're looking at surveillance system, which is, a great system to be able to help ministry respond quite easily to outbreaks that are happening. When you're looking at the human side of things, it's quite developed. You get the alerts coming in. You have teams that are being sent out to respond in real time. If you're to translate that into the animal sector, the alerts don't come in quite timely, and there's quite a lot of challenges that are happening along the way. One, if you're thinking about, and I'll use a classic example of anthrax. Most of the time you hear about anthrax happening when it has already crossed into the human population. But this is because you get the alert that someone is sick of anthrax, either cutaneous or they've eaten meat from an animal that has died suddenly. We rarely hear of, anthrax outbreak in animal populations quite timely. And you'd think if there was a system that, there is already a system, but if it was, fast, the alerts were coming in fast, then you'd prevent the outbreak from getting into the human population. But also thinking about it, and this is not me answering the question, this is just me setting the pace for a more discussion. If you're to think about it from the other side, if we do not help people understand the impact of one, climate change, or the impact of some of these interactions, if they do not understand that, then it's going to be, impossible. It's hard to get people to care about climate change. Not that they do not see what is happening. It is hard to get them to care about these things if they're worried about their next meal, if they're worried about sending their kids to school, if they're worried about shelter over their heads, they're not going to care. But if you're able to attach benefit to some of these innovations and letting people know what they can do, then it's going to help make this even better. And if you're looking at anthrax, say, and these are stories from the field, you can feel free to quote me. When an animal has died and they call the vets or whatever, the first thing that is going to happen is they're going to bury the animal, right? Or carefully dispose of the carcass. But what happens to the farmer who has spent time taking care of this animal? For them, it's a source of livelihood, right? And they depend on these animals to support their livelihoods. So what we are looking at is burying the animal so that people don't eat the meat. You've done what you can to control the outbreak in that human population. But then what happens to the farmer, right? So if that is not addressed, then what happens the next time the farmer loses the animal? They're not going to call the authority. And, a lot of times we've seen communities continue to eat meat from animals that have died. And this is why you continue to have these outbreaks, because with anthrax, it's pretty simple. It gets into the human population through handling meat of an animal that has died suddenly, or communities that are eating meat from the animal that has died due to anthrax. So it's like a two-way thing. Like one, you could show people where the gap is, and in terms of animal surveillance, I think there's innovation that could happen to make it much faster so that the alerts come in on time, and that can increase the response time. But also we need to start looking at the community aspect of it. Like when an animal that has died and the farmer has lost the animal, are we thinking of compensating the farmer? Are we thinking of routine vaccination? If we do the vaccinations, are we giving them for free, or are we asking the farmer to pay per animal? If the farmer has 60 animals, are they going to be able to vaccinate all the animals? In terms of cost, is that possible for the farmer to do that? If the farmer is only able to vaccinate one animal out of the 60 that they have, how effective is that going to be? So thinking about it from that perspective, we need to look at interventions that sort of also understand what the community is going through, if this is actually going to be effective.
Thank you so much, Shaban. I think I like that perspective. That is from the government perspective. But what is throwing to us is as the community, as the public, what is it? What innovations can we play around to see that we can be able to prevent, we can be able to detect response, we can lead the response, working together with the government to respond, but we have a role to play to prevent, detect. Obuku made a very interesting comment saying that in Uganda, we are the kitchen. We harbor all these issues around climate change, issues around public health emergencies. Uganda, we harbor all that. So what can we do differently? And before Obuku comes in to talk about what stakeholders can play, I want to pose it back to the public here, to the audience here. Shaban has mentioned some of the innovations in surveillance that the national level could do. I want to hear from you there. Again, what innovations, what more can we do? What more innovations can we do around this interface of human environment and the animals to be able to break this chain that is really impacting on climate change and health security? Do we have any suggestions? Yes, please, Doctor.
Thank you very much, our panelists, for this afternoon. My mind went to the recent outbreak of Ebola. And we became our own enemies because in the community, the traditional healers, people were taking patients there other than coming to the health facility. And we saw some people die there or even acted as source of infection and so on. So the innovation I was thinking about is probably using some of those traditional healers and training them on apps and some innovations we saw this morning. Like if we are training village health teams, they could also be included so that when we have an outbreak or a very infectious disease like that, they will have this knowledge that we shouldn't keep these people. And then, as Omar said, we could also have a reward system. Any alert you give us, any information you give us early enough, we will reward you in this way. In that way, we'll be able to detect early and also, make referrals that quick. And then secondly, we talk about vaccinations and surveillance of animals, whether they are domesticated or not. But the costs of vaccination and so on is very high. An ordinary farmer can't afford that at all. Talk about the birds, talk about the dogs and so on. I mean, if you have like 2-3 dogs to go through a whole 3 vaccines, initial vaccines, that's almost, you're talking about 1 million shillings. And the farmer will say, really, should I spend this on a dog or on my children? So what could be the innovative ways of that so that we include them, we make it affordable, we make it interesting, you know? Yeah, I don't have the answer. I'm just also putting my ideas out there. Yeah, thank you.
Thank you so much. I think those are wonderful ideas and I'll recap them. Anyone else?
Thank you. My name is Dr. Ibiju. I think personally, we leave too many things to the Uganda government. So the Uganda government is always dealing with a crisis. Always. They have failed to pay salaries. They have a new outbreak. They have a landslide that has happened somewhere. So why would they worry about something that has not yet happened? You get? When they have something that is happening right now. So I'm very sure people about to start complaining about December salaries and, you know. So I think we need more involvement about around the professional bodies that we have, making these things more lucrative for the private sector as well, for them to feel like they should invest in this. You get? So for example, I'm going to use 2 examples. We had the malaria outbreak, a very serious upsurge resistant to Artemether. Okay. Doctors knew about this for almost 2-3 months. Okay. Then the ministry reacted 3 months later. But then that health task force knew that I used Artemether, didn't work. 3 months later, that's when you hear a conversation about we are studying whether it's resistant or not, you know? So did those doctors, nurses, and those clinicians have the tool to report this outside of the professional chains, you know? They did not have, okay? COVID-19 second wave. Someone is working in an ER, sees 20 patients, they're coughing. How long did it take? And moreover, at national referral level, not deep inside Kaberamaido or somewhere. How long did it take for the government to, you know, start reacting? You'll find it's more than 7 weeks, you get? So even the educated, we are trying to target the witch doctor, but even the educated do not have ways to report this, okay? For example, right now, if you tried somewhere in Kaberamaido and you think you have a suspected case of Ebola, how long will it take you? And you're a professional, you probably know what Ebola looks like, okay, and what to look out for. But how long will it take you to alert the government? Because everyone has to go through the government. We don't have any mechanism to say, you people, I'm using this drug, it's not working, outside of the government line, you know? And this is a very long chain. It has the hub system, and if anyone remembers, the hub system was hijacked by COVID. So we no longer have it for these other things. It takes almost 7 days, more than 7 days, for a sample just to be transported and then back. You get? So, and we are dealing with a dangerous illness. Right now, if you go to a public hospital, we are having Ebola, right? And someone is suspected to have Ebola. You're going to take more than 48 hours to isolate that person. You get? And yet, during that time, this patient is being visited by half of the clan. Yes, we are very social individuals. Okay? So how have we involved the health workforce? We have professional bodies, we have these associations, but I'm very sure there is no direct way that someone is going to let other doctors know that these drugs are not working. And even if you try to let them know, they're going to say, have you done a study? A study has to be funded, has to be approved. You know, so there's several points that one can look at. But even as professionals, we don't have the ability to notify outside. And I think that's one side we can be looking at. Thank you.
Wonderful. I think this is a very interesting discussion, and being one of those key players in the global health security space, you raise so many pertinent issues that I feel that while a small group might know what has to be done, for example, he's saying, what should I do to notify someone that I'm seeing a strange illness, I'm seeing some resistance, what should I do? You'll be shocked that maybe someone in Kampala here might know, someone in another district nearby might know, but a health worker in Kaberamaido does not know. What is it that maybe we can do to increase coverage of understanding of what has to be done to be able to notify early, to be able to detect and notify, and also close the gap in response. Obuku was showing us the 717. If we are monitoring 717 at national level, but the people down there, our fellow healthcare workers, don't know what we are monitoring, we are now on. I think for me, the issues he has brought up really showed how there is not enough information out there to fellow healthcare workers on what has to be done. A few of us might know, but we need to increase that coverage. We need to let everyone know, if you see ABCD, report here. And if they report, we need to make sure we have a system in place to act immediately. But if you're going to take more than 48 hours to respond, as a healthcare worker, as a fellow healthcare worker, I don't get motivated to respond on time. So thank you for bringing up such very pertinent issues. And are there others who have some, just a minute, we had some innovations. I want to take note of all the innovations and then we recap them, because the organizers of this conference, I'm sure, would want this well documented. Let's get, we still have some time for this session, so we can use it very effectively to get feedback. Innovations on what we can do to avert these public health emergencies. Yes, please, Dr. Omar.
Okay, thank you very much, moderator, and thanks very much to our two presenters. We are looking at a very interesting topic, and I like the Venn diagram drawn by one of the presenters, where you highlighted the intersection between human, animal, and environment. But as you look at the three circles, I think all of us have to realize that they are human beings all over. We are human beings who deal with the animals, even in the human health sector, those are human beings, and in the environment, human beings of all levels, educated and up the high level and also up the lowest level. For me, I think we need to do something to make sure that we strengthen interventions in the community. Because at the end of the day, when you have this big outbreak coming out of changes in the environment, it's the community members that suffer a lot. When you lock down a district, you're locking down people and you're affecting people's life. So if we did something proactively to prepare the whole country to be able to support surveillance for these diseases, prevention for these diseases, maybe we would minimize the extent to which we are likely to be locking down. Because people who are doing mathematical modeling are predicting that the rate at which these outbreaks are going to be happening in Uganda is going to increase rather than decrease. So the earlier we strengthen community preparedness, VHTs, and ordinary people. My neighbor here, former honorable minister, mentioned about traditional healers. Those people are well respected in the communities. Actually, if you look at the competition between them and the formal health sector, they are more likely to be listened to than you, Dr. Obuku, and your group, which you used to lead, myself included, in our clinical courts. They can pass a recommendation and you can find it being adopted in the whole village, in the whole sub-county. So if we strengthen at the community level, every community, you see those VHTs, they are selected by communities, they trust them, they move amongst themselves, and they can tell you, they can alert you as a health facility about a practice that is going on that is likely to explode into something. So that's one. Dr. Buku, I'm delighted that you are leading a very important aspect, looking at policy and other things. When the country went into lockdown, harsh measures were instituted, which helped. But I remember when the community complained about how much they were being charged in hospitals, the ministry said, we cannot intervene in terms of regulating prices private hospitals are charging. You see that? So one can ask you, you can intervene and lock down. Why can't you intervene to limit the charges? Because they were too exorbitant. That's why some people believe that when these diseases that are likely to cause lockdowns come, they are actually not real. They are confirmed to benefit some people economically. Because you have capacity to do certain things, but when the community requests that you do something to regulate, you say, we can't touch. So I hope through the efforts you are leading, policies can be adjusted so that when we have a big emergency like this, some limitations can be instituted so that the people whose dead bodies were not being released because they can't pay certain amounts. And there was no assistance by anyone to ensure that people can be helped in terms of meeting some of those costs. Then, in these outbreaks that we have had, we have highlighted a lot of gaps in terms of infection prevention, infection control. And most importantly, before the COVID-19 lockdown, no one was looking at aspects of IPC in the health facilities. But we have reached a point where we need to even do IPC in the communities so that per homestead, people know key practices. And I think we need to find innovations, how we can be able to ensure that communities can wash hands, can social distance, can wear masks, where a community member is coughing chronically. And now we can use social media and these upcoming technologies to be able to spread. Right now, social media can bring down a good campaign. So whenever we have a good campaign, we need to be aware that those who are decampaigning are going to come in full force. So we should always be able to counteract. But we shouldn't just keep quiet, because if you just keep quiet and for them they are continuing, you don't know which direction your community will go. So thank you. Those are my submissions. The final one, how can we use the school health program? The ministry has a school health program, and the biggest population of Ugandans are living in schools. Is there a way we can find what attracts the school-going children? Now they like a lot of things to do with technology and slotting things that can help in terms of climate protection, but where the climate has been destroyed and the catastrophes have come up, how do we now utilize the aspects that they enjoy most to educate? Because when you educate them and you send them home to educate the parents, that is another free channel for you to disseminate. Thank you.
Thank you so much, Dr. Omar. Very wonderful suggestions there. I know we are running short of time, but the discussion is getting really heated. So I'll have one more person, and then we will wrap up that and have Dr. Obuku take a chance to make his submission too.
Good afternoon, everybody. I'm God Shadrach. According to me, I think we should increase on sensitization, and we still have some problem with UNBS because we have seen mob drinks in the supermarkets and whatnot, whereby they don't have their label, and also some shops and whatnot, they are selling expired drinks and eats, and the UNBS is not taking action to do what it is supposed to be doing. And another thing, as doctor was presenting, we have seen that there is more paperwork. We still have gaps between policies and implementation of those policies. And I've seen doctor talking about VHTs, and I don't know if she's aware that VHTs are voluntary in Uganda. And demography, because those VHTs, you find that the village is having more than 200 people, and that VHT is there to represent them, and she's a volunteer. So I think they should look on that, and they give them some allowances such that they can be motivated to do more healthy work. I think that's all. Thank you.
Thank you so much. Okay, maybe what we could do is let's ask one more question, because I'm sure some of the responses could be related. We'll just start by requesting Dr. Oboko. I take note of all the hands that were up, but I just want to put in this question so that as we respond, maybe your responses can be combined. Dr. Oboko, in your presentation, just recap my question. You mentioned that there's something that you talked about the seasonal calendar. We have a seasonal calendar that a few people know, but many of our stakeholders, many of the my mother down in the village might not know about this seasonal calendar. Maybe someone's grandfather up in West Nile or in Bududa, where these floods are, is not aware about this seasonal calendar. So as these different stakeholders that I've mentioned, what role, what is it that you think they can play? We have this information that we have with us at national level. How do we disseminate it down there? How do they get involved? How do we ensure that a whole of government approach is used to be able to reach out to these different stakeholders to avert the impact of climate change on health security? Dr. Oboko, you could start, and the rest of the team here, your involvement in this discussion is still very welcome. Dr. Oboko.
Yes, but you know, I can use the high level approach and talk about SDGs and partnership, HDG 17, and look so complicated, those students will go out praising me. But also I can come down to reality. I can come down to reality. And I've put them into 3 points, broad points. Because sometimes we discuss operational issues and strategic issues. You get what I mean? If we go to school health, that's an operational issue. How do we do it? Yeah. But the bigger question is, do we want more government or less government? And that man from Kaberamailo, you know, he's from near my village. I think he was tapping my thoughts. The Kaberamailo man. Do we want big government or small government? Because everything is government. Even donors nowadays are saying the government is not even committed. You get what I mean? When it comes to issuing money, they are quarreling who should have the money. So do we want big government or small government? What is small government? Means government concentrates on very small things, and the rest is driven by the private sector, including partners. You see, if the United States government says, guys, we're going to give us money, this Ebola will reach New York. It reached New York, and some people got infected, including healthcare workers. Yeah. So that it's the international community must know that it's also their responsibility to support weaker governments because of historical structures, you know, which we must readdress. So this is a philosophical kind of thinking. Once we resolve that one, then we agree on how to invest. Let me give you an example of that. Second, your question of Ministry of Health doesn't want to do this about prices, bodies being retained. It's a question of more government or less government. More government can come in 2 ways. Government can disturb the market by oversupplying ICU beds. When you oversupply ICU beds, okay, demand and price go down. So nobody sees the advantage of going to pay 5 million a day in a private facility. But for as long as government is not supplying ICU beds, and ICU beds are being supplied by the capitalist intent of profit, you are going to have someone charge what they want. People are charging what they wanted. I took my mother-in-law she got a stroke during that time. And just the day stay, when I came to pay, they said I wanted to swallow the owner, who is my colleague. You get what I mean? Who is my colleague? It wasn't a COVID, but just stroke during COVID. COVID negative, 2 points. I said, you man, which salaries are you paying your doctors? You get what I mean? Everybody had become driven by the profit intent. So if you have less government, private sector can play a role, driven by profit. How can private sector also be supported? The international community and the World Bank and so on can extend loans for people to increase the supply of, for example, beds or ICU. This is after the fact, isn't it? So that is big government, small government. That debate continues. But personally, I was very displeased to see the ambassador of USA, talking it down to the minister. The ministers are going to parliament to sort out. It didn't look good in terms of sovereignty. Okay? And this is a question we need to resolve. We need to resolve. The other question broadly is data. Everything we are talking is data. This information dissemination is data. The decisions are data. What the Kaberamaido man is talking about is data systems. And the world is moving towards the big data economy. So we must quickly invest in collecting all this data, HMIS, DHIS, whatever. But now, the other question is data use. Beyond data use for decision-making. Beyond decision-making, which we always think is in the parliament and the Ministry of Health, it should be at the district, it should be at the hospital, it should be at the individual. So data is the bigger question. Now, the final thing about stakeholders, who is a stakeholder? Stakeholders, all of you are stakeholders here. You hold a stake. And when you talk about the community, sometimes Zebra, my colleague there, Sekaba, he forgets that, when I heard you saying the highly educated and royally educated, my friend, that thing doesn't exist. In reality, it does not. If you saw the struggle for oxygen at Mulago, what I called the oxygen hunger, it didn't matter whether you're a minister. Actually, the managing director of Stanbic, when we invited her for a session, she said, your bank account didn't matter. So the question of high income, low income individual, time comes when actually the biblical saying is judgment day. COVID was judgment day for all of us, where everybody stood before his God. Isn't it? You get what I mean? It was a depiction. If you're a Christian and you follow biblical teachings, I think Islam also has that Jannah, but I don't know whether it's in that hellfire. And so they are highly powerful, but lowly interested stakeholders. Highly powerful, but low interested stakeholders. Once we map those, we shift them and shift their interest. Most of us are highly interested, but powerless. You get what I mean? All of us here, we are very interested. Now I asked my question. She said, we are taking notes. I've been organizing conferences, since I was a medical student. What happens to this deliberation? One of my mentors, Professor Maswa, says, I don't want to come for a meeting if no decision is going to be acted upon. So I'm going to say, Judith, this meeting which I've come for, these brilliant ideas, where are they going to end up? Is it a report? And this is my space. I joined Professor Sewankambo 10 years ago, doing systematic reviews, policy briefs, and so on. In the middle, when I became the president of UMA, I told my colleagues, do you know we were in the meeting there with the government and nobody talked policy brief or research? You know what I mean? So I said, we need to change the tactics. A newspaper article in op-ed is more important than your systematic review or policy brief. This is what we discovered. So when I joined my team in IDEA, I said, can I write newspaper articles? They say, you first go slowly. Because you see, it has issue. So how do we communicate for impact? Because I can guarantee you this conference report is going to be put somewhere. The brilliant ideas here of the future, because I call them the future and they were very serious. What is going to happen? to this thinking. I rest my case there. But one of the most important stakeholders are the youth. Let's give them the power to be part of this action. I understand political education was corrupt from schools. Now, can we introducing the climate change education? Because you see, we are doing physics, mathematics, PEM, you become a doctor. Now, we did that 20 years ago. The weather or climate was not the same. It has changed. Why are we still busy? The rat, the rabbit. And now the challenge of today is not the rat, although they cost 8 million for vaccine. But the challenge today is the climate. But we are still producing the doctor with the same mentality of go to the lab, the digestive system, then come out. You get what I mean? So can we?
Thank
I
you
close.
so
I
much.
close.
Thank you so much, Dr. Obuku. I want to give just one person to make his submission. We would like to close this session. It's been very, very interesting. Let's give one person to make his submission, and then I'll wrap up with what we've had here. Thank you.
Okay, thank you so much. I'm Ivan Chemos. I'm a medical doctor by training. I happen to have been part of the response to Ebola recently in Masaka, and I've learned a lot from it. During the response, we were able to unearth a yellow fever and a Crimean Congo hemorrhagic fever during the response. What does that show? It shows that the surveillance is still very poor. So I think we need to really strengthen our surveillance in the districts. Putting that aside, like in the previous presentation, we've seen that there is a lot of interaction between the environment, the wildlife, and the humans. So we need to put up serious policies relating to human interaction and wildlife, because there are people who live next to conservations next to the wetlands, and they do encroach these wetlands. They do encroach this conservation, like the forests. They go for poaching. So we need to put up serious policies to make sure that these people do not encroach the wild, where the wildlife is. And if that's not enough, we can do social behavioral change to those communities such that they don't encroach and interact with the wildlife. Thank you.
Thank you so much, Chemos, for that. I just want one more person to talk about the people at what Ugandans call Omuntu Wowansi. What is that? What is it that that person can do to make a difference in terms of averting the issue that we are discussing? We have talked about the technical people, but the person down home, your mother in the village, your grandfather, someone back home, what is it that they can do?
Judith, this point here, it was my first point, but things became many. You know this thing, you said the calendar. It's not disseminated. So let me tell you, it is disseminated. Like in Elgon, there are usually cracks on the ground before, and these people know. This ministry, the office of the Prime Minister, sends people actually in advance every year to warn people to leave. The biggest question is, where are we going? You see, the thing is options. Information and diagnostics sometimes is there. You know, 30 years ago, if you got a diagnosis of HIV, you know, what do I do? It is like cancer today, isn't it? But now we have solutions. You can go and test everybody because we have a solution. But now we go there, find the cracks, we tell them floods are coming. What do we do? And that's the problem of the Muntu Awansi. How do we support them to find solutions to what we have, the problem?
Thank you so much, Oboku. One more comment from Shaban before we close. I'll wrap up our session. Shaban, do you have one comment to make before we close?
I think the comment for me that I would use is the interaction between humans and animals is a very relevant one. But just to build on what he has said, it's almost a discussion of looking for sustainable alternatives to energy. The alternatives are there, but are they affordable, close to what is there? So if we don't crack the code between what we are creating versus the availability and accessibility to the people that you're calling Umuntu Awansi, then no matter how brilliant your ideas are, no matter how much innovation you do, if it doesn't translate into the setting of the local people, then it's a losing battle, really.
Thank you so much. Ladies and gentlemen, today's session has been really, really wonderful. The participation has been immense. But as we wrap up this session, there's been a lot of suggestion on innovations. What is it that different stakeholders can do? And wrapping it up again, it goes back to what the Global Health Security Agenda has packed around prevention, detection, and response. When we talk about some of the suggestions that have come forth, involvement of traditional healers. Think about traditional healers as key opinion leaders in the community. These are key stakeholders in the community. If we add that point with strengthening community interventions, strengthening community resilience, to be able to have surveillance systems, to be able to have strengthened infection prevention and control, how do we bring the community in here? Into this space? The community is us, the community is different people back home. How do we ensure that we have resilient systems to be able to strengthen health security? And the community not leaving out our key opinion leaders is something that has come out very strongly. The other that has come out very strongly in this session is, okay, yes, they have, you have involved them. They have been able to report and notify some of these emergencies, some public health emergencies, but can we have a reward system? Can we have a reward system that can at least provide a reward to some of these individuals that come up with, that notify these emergencies? We have village health task forces, village health teams that are volunteers. What is it that the government can do to see that these people are not just volunteers, but can at least be provided some sort of facilitation to make them do their work easier? Again, innovations around prevention are very important. We have many of these zoonotic diseases that are coming up. Do we have vaccines that are, does globally, are there vaccines that are readily available? That's number one. When we started when we got the current outbreak of Ebola, there was no vaccine for Sudan Ebola virus. But okay, it's one thing to have the vaccines. It's another thing to see that these vaccines are available and affordable to the population back home. What is it that can be done to see that these vaccines are available and they're affordable and accessible? How do we close the gap between policy and implementation? We have quite a number of good policies. What is it that we can do to close that gap? How do we bring in the private sector? How do we engage the private sector for resilience of our public health interventions? We have innovations around school health. We have the school health program. What is it that we can do? What can we tap into the school health program to promote health and use them as champions to champion health going forward? Lastly, we have generated data. A lot of data is being generated. How do we utilize this data for impact? How do we utilize this data and communicate effectively to see that every key player in this space knows what their role is, and we can continue using this data, not just for implementation, not just for writing papers, but to change practice to promote health. Ladies and gentlemen, it's been a wonderful session. Thank you so much for your participation. Our distinguished panelists, thank you so much for making the time, and thank you for leading the discussion. I want to thank you all for your participation and wish you a good afternoon ahead of you. I've been informed by the organizers that from here, we are expected to go to the quadrangle where we received our bags for the next program. Thank you all. Have a good day. Bye. Thank you.
Coming back into the main room, could I just ask Dr. Martin and Rachel to join us on stage? Rachel, you are UNCDF Thank you. So, already introduced Dr. Amina Zawadi for joining us. On the stage, we're also joined by Dr. Ruth Chaweko, who is head of Impact and Scale for the Academia IEI. It's very important to really innovate sustainability and scaling. You know, many of you have had, so let's do. UNCDF is really making changes in the health innovation space. I've had fantastic conversations from them today about their projects, and I think Dr. Amina white paper, which has some interesting case studies that UNCDF have produced around health innovation. We were also supported by other groups such as the World Health Organization, the Africa Resource Center, Marsh Insurance, Broadreach, and some of our media partners, including City Branding, Shark Media, Superior Promotions, Solace, World Class Printers, and Inline Print Services. So we would like to extend a thank you to all of those. So without further ado, I would like to invite our Permanent Secretary, Dr. Amina Zawadi, to give the closing remarks today and to thank her most wholeheartedly for spending such a long time going through all the exhibitions and for joining us today. We are very honored. Thank you so much. Thank you,
You know, coming from government, I have to observe so many protocols. But I believe as I stand here today, I am going to be as much informal as possible because I'm dealing with young people who don't want the politics of protocol. So, ladies and gentlemen, in your capacities, I greet you all. Good afternoon. I don't know whether it's evening already. Good afternoon to you all. I am really excited to be here this afternoon. Well, many times when they call us to launch or open conferences or close them, you start wondering, what are the talking points? What am I going to talk about? But today I came with a speech, but I'm going to talk from the heart. First of all, I thank all the innovators because you're the reason we're here today. If the Academy of Health Innovation had hosted this conference for innovators and no one turned up, we wouldn't have had a conference.
So well done. Thank you for, heeding to the call that was put out. I also thank the Academy of Health Innovation, UNCDF, IDI. I've seen Makerere University somewhere because it hosts IDI. I am homegrown in Makerere University. That's where I came from to join government. So I still have my umbilical cord not so detached from academia. I know the importance of, growing and nurturing innovation together with the academic, environment. And I am one person who is promoting the linkages or strengthening the linkage between academia, government, private sector. At the ministry, we are also strengthening the innovation ecosystem because 70% of our population in Uganda today is made up of young people and with innovative minds and so many solutions that, run in their heads. Last week, was it last week? Yes, I was in Estonia, and we went to see a hub where children go. There is no curriculum. It's about children of between 8 years and 15. They are given spaces. There is no curriculum. They are only mentors, and people come up with so many fascinating ideas. Just like I have seen when I was walking around, the project on the drones. I know many people suffered because they could not walk to hospitals during the COVID times. But now that we have COVID, we cannot say that we will not have any, lockdowns again, but we have to prepare for any future lockdown if at all it happens. But even today, we see the other day, because of Ebola, some districts were locked down. So people suffer because services cannot get to them. When we come up with solutions that can be able to, address these challenges, then we give thumbs up to ourselves. Winston Churchill said that healthy citizens are the greatest asset any country can have. And so being a part of the solution brings me immense joy. And you being part of the solution that brings healthy citizens to be in our countries is very good. Just imagine if we woke up today and there's no one in this country, where would we be? During COVID, we saw some countries that were almost wiped out. But if we have these solutions come in handy, that will be very good. Some of them are preventive solutions, just like the knowledge bases we have seen. I think some of you, I personally had a patient one time, my father got cancer. That was over 10 years ago. And when he was diagnosed and were told cancer, everyone thought it was the end of the world. You don't know what to do with yourself. You don't know what to tell the patient. You don't know where help is and all this. So we started running around. And then to some people, it looks like it's any normal day because they've gone through it. And then for you, it's the beginning of this journey. But if we have these solutions come around where people can get information readily accessible and available, then we'll have, a better way of dealing with our lives, and also an efficient population that will have to conduct the business of this country. So once again, I need us to give a round of applause to all of you for taking part in this path to greatness in digital healthcare. And I mean it, because having talks on data and bioinformatics, equity and inclusion, many times some people are left out because we don't have solutions for them. Having a workforce that is building capacity for great impactful innovations, and more a perfect reflection of Uganda's digital transformation program. The Ministry of ICT is heading the digital transformation agenda for this country. So, and when we talk about digital transformation, ICTs or innovations cannot stand alone, but they are a support of all the sectors that we have. So we have innovations for health, innovations for agriculture, innovations for education, for tourism, name it, all the sectors that we have in this country.
require people like you to come up with solutions that we can afford. We've been talking about, I think I saw that device that is for testing the child's heartbeat. There is a project with a device for the, yeah. I didn't get the name. Yes, that one. But you know, some of these devices, if we are to go to any ordinary hospital today, people would have to pay hefty to get the services that these devices have to offer. So if our own can come up with solutions that talk to our challenges, then we know we have cost-effective solutions that will enable us survive. As government, we have intentional drives. I have been telling Dr. Rose about the fact that we have worked with the UNCDF before to support us on creating, you know, they call it enabling environment, but the young innovators would like to know what this is. Creating the right regulations and guidelines that we can follow to develop our innovations. Things like intellectual property rights are important. Some of you have come up with these ideas from your heads. You're too young, you might not know what it takes for us to have this innovation in place, but for as long as anybody uses it, the credit has to come to you, or you have to own the right to these innovations. So we are putting all these systems in place to protect the innovators. And when you develop these innovations, they are not only to be consumed by our Ugandan market. We can even be able to export them and use them in the wider continent, Africa, and even globally. I'll tell you a story of Estonia. How many of you know Estonia or have heard about it? It's a very small country near Russia with 1.3 million people. I think even Kampala has more than that. Only 1.3 million people, but 99% of all its operations are done online. Everything you do is online. I think the only thing they don't have online is toilet paper. But everything is paperless. Even weddings, you can do marriage online, you can do divorce online, you can buy property online, you can even apply for e-residence online. So we have used that country a lot to, you know, try to come up with some lessons learned that they, for the journey they have walked through digital transformation, and they have not taken a long time. And in Estonia, 1 out of 3 people that you meet has a company, over 1.3 million. So about 300,000 people have companies, and these companies don't operate for Estonia only, but they operate globally. They have over 7 unicorns. A unicorn is a company that is 1 billion, that has revenue of $1 billion without any shareholding. So someone has built up this company and then they have generated that kind of revenue. One of them is Skype. All of you know Skype. The other is Bolt. Bolt is like Uber. It's Estonian, and many others. You can go and read about them. So if we create these spaces, we are mindful of the fact that, you know, innovation is key. And if we get all of you together, sometimes you don't have to, you cannot, if you want to, they say if you want to move a longer distance, you have to move as a team. But if you do it alone, you will move, you know, shorter steps. The innovations you have, I saw one that was I told the lady who was explaining, she said it's a knowledge base. When you want to know any information about what's happening in the health sector, you go and ask. Then there's this other app where I ticked that I was excited today and not happy. Yeah, if I want to learn about, you know, some of these, you call them chronic diseases. You talked about diabetes and blood pressure and all that. So we can collect these ideas. They're all talking to, you know, they are all trying to address a problem of lack of information. So we can even see how can we get them to do a more impactful project. These kind of discussions are what we are doing as the Ministry of ICT in spearheading the innovation ecosystem. During COVID, I think the government of Uganda extended a host of ICT resources to the Ministry of Health. We had some applications that were, I think even at the airport at one time when people were coming in, doing the COVID tests and then clearance, these were applications that were developed by, with the support of government to help our citizens. We have digital technologies having enormous potential for our country. We are aware of that, but we also know that as government, our role is to provide innovators with spaces. There are those that don't have the spaces where to grow their innovations. There are those that require internet. There are those that just, require building their skill set. Some of you develop innovations that don't know how to market them. I have gone through the innovations that, were being displayed. And yes, people were enthusiastic and energetic to talk about their innovations. But there are those who say, I want you to tell me about your innovation in 2-3 minutes, because sometimes they call it the elevator pitch. And someone does not know how to do that elevator pitch and bring the message in those 3 minutes. You need an introduction, a body, conclusion. What do you want? What message are you putting across? So these skills we have to impart, and we are coming up with a program to just support the innovators with these soft skills and business related skills to nurture their innovations. We also appreciate the Ministry of Health as a ministry for keeping up the fight against the various pandemics that we have had as a country. The latest being the Ebola pandemic, but before that, COVID-19, and for encouraging innovation and digitization in our country's healthcare system. As the Ministry of ICT, we stay loyal to continuing doing everything that we have in our power to present a tech-based or technology-based environment, investment connections, because if you have an endorsement from the ministry, if you have an endorsement by government for what you're doing, then you have so many opportunities. I know UNCDF is here probably if they didn't know that government was behind this, or if they didn't know that academia was behind this, they would probably never have supported. So having come from academia and knowing the politics of getting projects successful, I know what it takes, or I know the power of collaboration and partnership. So the Ministry of ICT is ready to support this community of innovators. We have various programs at the National Innovation Hub in Nakawa in UICT. We have the Uganda Institute of Information and Communications Technology. How many know it or don't know it? You don't know it? Google it. But we have the National Innovation Hub there. And we don't only support innovators in the Central Business District or in Kampala, but we are also supporting innovators in different regions. We are supporting innovators through the universities in the various regions. We have so far supported Kabale University, Soroti, and Muni, and set up hubs where innovators in those communities can come to the university and use those spaces. Because we know for one to innovate, they need the thinking space. They need, some need computers, but if they do have, if some have computers, they do not have connectivity. And they also need mentors and, kind of programs to raise their, to build their capacity in the innovation ecosystem. And thereafter, if we are, campaigning for getting you job opportunities or tapping into markets where your innovations can thrive, then you can be able to compete globally. Uganda recently joined the Digital Public Goods Alliance, in June 2021. I don't know how many know about it, but UNCDF is part of those partners and UNDP, I think. This Digital Public Goods Alliance is a consortium where we are saying that, technology sometimes should be shareable. And when it is shareable, it becomes easy or cheaper to use. Just imagine if we are paying to use the roads that we use today. How much would we be paying moving from one road to another? But we know how important roads are. So we say, let the roads be free, but then probably the services that are on these roads are the ones that we should be able to cost. So we are also mindful of the fact that if we give you things like internet free or subsidized, then we have cloud services for you, then you will have your innovations done cheaper and better. The ministry has established a BPO, that is Business Process Outsourcing and Innovation Council, to foster collaboration between the various Ugandan ideas and advancements that there are, while also providing young people all over this country with employment opportunities through what we call business process outsourcing. His Excellency, the President, he knows that 70% of his population are young and many of them are jobless, but while sitting on very rich ideas. So we want to leverage on that to create an ecosystem that is going to support innovators to grow. We have come up with programs like the parish development model to support, people in the low subsistence economy, the farmers. But then for the innovators, we also have ideas for you. Many of you might say, now how will I benefit from PDM? It's about digging and what you're not interested in that. You're more of a tech person. We also are preparing programs for you and we'll soon put out calls. Of course, we are ready to collaborate and partner with the Academy of Health Innovations as we grow our innovation ecosystem. We'll have calls that will come out to support innovators. Please be ready to respond to these calls that are aimed at building your capacities and opening up doors for you. I will close my speech with the following phrase. I don't want to say much. I know I'm a lecturer and I don't want to turn this into a lecture, but I'll close with this. At least 40% of all businesses will die in the next 10 years. Why? Why do I say that? If they don't figure out how to change their entire company to accommodate new technologies, they will die. And this is a clause or phrase by John Chambers of Cisco. So my message to you all is that let us keep the technology torch of the Pearl of Africa burning. And I say this for God and my country. Thank you.
Thank you so much. We officially come to the end of the Health Innovations Conference, and I think it's the beginning of the next Health Innovations Conference. I would like to state that the Academy has a memorandum of understanding with the Ministry of ICT that Dr. Amina Zawede signed. So you can see that she already has a relationship with us. We want to be that platform that can reach out to the health segment in terms of innovations, because we are hooked into academia. We want to go to those grassroots people who have innovations and need our input. There was a question yesterday from a gentleman that the most learned people don't have the best solutions. yet those who might not be so learned have the solutions. The academy is here to be that platform, especially for healthcare. Our interaction with the community has revealed so much potential, and we want to be that platform that will give them that opportunity for you to see and support, and then work together to adopt them for our healthcare systems, and then also importantly, make them commercially viable. And then URA will tax them. But it all comes back to build that economy, because I know very well Estonia has benefited so much. So feel free to reach out to the academy. We are here to support you. And in the next conference, we shall be bigger and better. And you will be the ones sharing more of what you've been doing in the last 12 months. But it's a journey for us to the next conference, and we want to walk that journey with you. So thank you so much, and see you in the next couple of days, because the conference continues even after here. The work continues, and we are available. God bless you so much. Hi, if you're still here, the youngsters, the innovators, our delegates, our VIPs, please, you're welcome to take a photo with Dr. Amina Zawede. The media team is going to show you how we're going to take this picture. Kindly, yeah, we can take it here. Yeah, we can take it on the stage. So if you want to be part of this picture, please come. The media person will. And as we get ready, can we possibly give a round of applause to the organizing team, the people in black? They have made this very, very excellent. So we are really grateful. After this picture, I will invite the organizing committee to quickly take a picture with the PS. Very quickly, please, very quickly. Organizing committee, please. Thank you. All right, thank you so much. Organizing committee, please. Can we be fast? Please, organizing committee, guys, can we make this fast? Organizing committee. Oh, guys, can we stand behind the chairs and Dr. Rose and Dr. Zawedi will be in front. So just for the purposes, can we go behind the chairs to make it a little bit better? Oh, okay, that's okay. No, they stand down.
Darling, expiry date.